Ready? Okay. Good morning, everybody, and welcome to Research Day 2026. Allow me to apologize for starting a few moments late, but we are now about to get the ball rolling. I am Penny Maloney, and I will be your chairperson for today. Research Day 2026 is advancing under the theme Evidence in Action, Advancing Health through Research, and it promises to be a very engaging and educational day. Just a few housekeeping bits before we move forward. Bathrooms, there are 2 bathrooms in the building, one located right here to my left and another at the back by the exit. Cell phones, please put your cell phones on silent or vibrate. We wouldn't want cell phones to be interrupting the presenters, breaking their concentration, etc. There will be a break just about 10:30. Light snacks, refreshments, tea, water will be provided for you. And then we continue down until 12:15. At 12:15, we will get a lunch break. Lunch has also been provided for you. So each presenter is going to have just about 15 minutes to present to you their piece of research, after which we will open the floor for a question and answer. There's a microphone in the center of the aisle, so please go to the microphone. I know that we can all speak loudly, but we want to use the microphone because we want persons who are tuning in virtually to also be able to hear us. So you go to the microphone and you give your question, and the presenter will have the opportunity to answer it. You're also free to just make a comment if you want to add something to what was presented. We're also welcoming questions and comments from those joining us virtually. So we are being streamed on the Government Information Unit YouTube page and also via the Ministry of Health and Social Services Facebook. So persons are invited to, at the end of the presentation, to put your questions, your comments in, and Ms. Charlene Lindsay, she will advance those and you can tune in for the answers and responses. So with that being said, we will now forge right ahead. It's my pleasure to welcome the Honorable Creston Buffon to the podium this morning. He is our Acting Minister of Health and Social Services, and I'd just like to get a few words from him before we move forward.
Right, thank you very much, Mistress Maloney. She did say a few words, but you don't give politicians few words. You have to be careful with that. First of all, I bring you greetings and commendations from the Substantive Minister, Dr. Ingrid the Honorable Buffon, who is away on official duty, some very important duties she's working on at this particular time. I'm absolutely delighted for this opportunity, so much so that I believe I have forgotten my manners. Good morning, maybe it's just nerves, but good morning, everyone. Health and research goes a long way, or goes hand in hand, and while I'm not Dr. Buffon, everyone knows that the health is the most important part, or as they say, it's the wealth of any nation. Today's theme, I believe, is quite fitting, I must say, evidence in action, advancing health through research. And what I get from that is that with all the research, with all the evidence, with all the data, we must be able to advance health and healthcare as a result. So beyond the reports and beyond the presentations and the academic discussions, the true value will only be realized when this evidence becomes policy, becomes programs, and clinical practices that will transform the health of our people. Now, I'm quite aware that I'm addressing a room full of professionals, and as such, I might be the last to tell you about HPV prevalence studies, or tell you about morbidity and risk factor prevalence survey that has been done over the last year right here in Montserrat. But what I can say is that as a direct result of these studies, they have provided the evidence in our, they have provided the evidence in the development of our cervical cancer elimination strategy and also guided the mental health and non-communicable disease policy. And for that, I think you should give yourselves a round of applause. Today's program addresses several important health issues affecting Montserrat and also highlights the value of locally grounded research in identifying gaps, especially as it relates to the limited resources and developing practical interventions that addresses the needs of our population. Now, I know that this ministry would know more than any other ministry about limited resources, from medical evacuations to new hospital or salaries or even maintenance. This ministry is quite aware of limited resources. Anyways, I want to therefore thank and commend each presenter at this time, well, for their time, for their discipline and their commitment required to undertake this work. Each healthcare professional, the patients, partner organizations, and community members, especially our community members who have had to put up with us with all the questions, some of which, begs the question. Thank you for your tolerance, for your information, for your experiences, and support for these studies. Today, I want to encourage us to be a part, to share in the information and to give your input. I know that the Ministry of Health and Social Services remains committed to fostering a culture in which research, monitoring, and evaluation remain critical to the planning and delivery of healthcare services across the country. I'm excited to hear, I'm excited to learn, and I want to wish you all a very successful day and urge participation and engagement. Thank you very much.
Thank you very much for those words. So we will proceed with our first presenter, Dr. Dorothea Hazel Blake. She is absolutely no stranger to the podium here at Research Day. In fact, Research Day is her brainchild. She is a medical technologist, an epidemiologist, and she is the immediate past director of primary health care. She will be presenting this morning on barriers and facilitators to adherence to the DASH diet on Montserrat. And we put her first this morning because last year we got a little prelude of this study. This study was ongoing at the time, and we were told about it right at Research Day 2025. So I will invite her now to come forward and to tell us the findings and what we will do with those findings here on Montserrat.
Morning, everyone. It's good to see you all here. I'm not going to waste my precious 15 minutes telling you how much I miss you guys, but we will continue. As Penny said, this is what we're going to speak about this morning, but I also have to figure out how to operate the There you go. All right. Teething problems. Right. So this morning we're going to talk about the barriers and facilitators, basically what's blocking and what is assisting persons to adhere to what is called the dietary approach to stop hypertension, or the DASH diet on Montserrat. So why does this matter? Hypertension, high blood pressure, whatever you choose to call it, is a reality among us. The figures in front of you, 57.9% prevalence, meaning when they surveyed persons in the region in the Eastern Caribbean among adults 40 years and over, that percentage was found to be living with hypertension. You heard Mr. Buffon just speak about the research we did on prevalence. Back in 2022, we did a household survey on Montserrat, and we found that 34.5% of persons reported being diagnosed with one or more chronic illness. And note I said reported, because reporting studies is notoriously known for being underreported, because people go into denial, they don't accept the diagnosis. So if 34.5% of people reported, then you know that the figure is higher than that. So it is a problem throughout the region. It is also a problem here on Montserrat. What is known also is that dietary approach, meaning how you eat, is central to preventing blood pressure from continuing to increase. As a matter of fact, interestingly, as I was getting dressed to come here this morning, I had the television on a United States station, and they were talking about the DASH diet on the Today Show. Not an advertisement for the Today Show, but this is what was happening. So as I said, the dietary approach to stop hypertension, it's an eating plan where we may not call it that many times. You might not go to Dr. Skerritt and she say, this is the DASH diet. But what she will say to you is that we want you to eat more of this and eat less of that. So you must eat more fruits and vegetables, more whole grains. So if you're cooking rice, perhaps the brown rice over the white rice, but we know how that goes. If you're having pasta, the brown pasta, the whole wheat pasta is preferable over the white pasta. Nuts and seeds, meaning nuts and peas in our language. So the pigeon peas and the red beans, the whatever peas you like, they are better to have than not to have. Low-fat protein, preferably fish, but if you like chicken, then the low-fat part. Not the chicken wings that we all love. That's where most of the fat is, but the less fatty parts of the meat. And of course, unsaturated fats. Again, notice I said eat more and limit. I don't believe, and most of us don't believe in the all or nothing. If you say to people, you can't have this, then what do they want? Immediately, that's what they want. We're saying learn to limit these and increase these, so that at the end of the day, you're belly full, right? But not full with all of the wrong things. And then we're going to limit salt. We know that food without salt takes time to get used to. It don't taste good, let's be frank. But you limit. If you slowly decrease the amount of salt in your diet, then you don't miss it as much. Don't keep adding sugar. Foods come with sugar already. Do not add sugar to them. Don't bother with the high-fat meats and dairy, as I said, and the refined carbs, which is the ultra-processed. So again, the white rice, the pasta, the white pasta. If you're having, you can't have it maybe more than once a week. All right? And of course, the saturated fats like butter, you limit those. So what did we do? In this study, we decided to use what's called a qualitative approach. Let's go back. Again, we heard earlier of the prevalence study, where one of the recommendations actually from the prevalence study, when we discovered that 35.6% of the population were reporting, was that we needed further study. So in agreement with what Mr. Buffon said, yes, we're taking the next step. So we found 16 adults who are living with hypertension, who've acknowledged that they have hypertension, and they happen to fall between the ages of 40 and 79, and we recruited them at the health center. So they came and we said, would you like to talk to us? And they said yes. Some people said no, but this is the number we had. What was done was a semi-structured interview, which varied from 20 to 40 minutes, where my colleagues sat with them. The same person interviewed all 16, because you wanted to eliminate the likelihood that maybe I asked the questions differently to how he would ask. So my colleague interviewed all the persons, and this took place between June and August of last year. And the responses was transcribed, what says they are verbatim. Every word they said, because we recorded it. Every let me see, was recorded, and with the assistance from Keele University, they were transcribed into paper. Again, every repetition, you didn't take anything out, so you had what's called a verbatim account of the interview. Then it was the interviews, all 16 of them were analyzed using what's called a theoretical domain framework. Now, I'll take 2 minutes to tell you a little bit about the theoretical domain. It is a tool used to help understand why people behave in a particular way. Why they do certain things and why they do not do certain things. So for example, why do they take their medication? Why don't they take their medication? And it's not necessarily a public health tool. It's more of one of those psychological assessment tools that Dr. Imaro could probably, and Mr. Bamishele could tell you more about it than I can. But it was a useful tool. We were taught to use it. And in this instance, 3 of us went through the transcripts independently, looking for certain themes, looking for certain mappings, and then we compared our results so that you have what's called more rigor. So it was not just Dorothea Hazel or Bill Berners-Lee or Nadine Joubry. Those are the 3 people who facilitated the study, but it was the accumulated effect of our combined work. So here is the ratio. You can see we had 10 females, 6 males, 12 of whom were born in Montserrat, and the others were all Caribbean residents, but who live here. And you can see the mean age. So what did we find? We found that 5 themes emerged. And we will explore the 5 themes, which make it a little bit easier. So the first one was the understanding of hypertension and the dietary approach. People understood hypertension. The participants saw hypertension as an urgent and tangible threat. It wasn't something out there. As you see, one person could tell you, my sister died from hypertension at a young age. All right? So many linked it to, somebody has said somebody had a stroke that I know in the village. So they see it as a tangible threat. And they also understood a little bit that the DASH diet, again, they may not call it DASH, but they understood that what can happen, how they should eat. They know they must reduce the salt. Dr. Skerritt said to do this. Ms. Taylor said to do that. They could tell you this. So this is a powerful asset, because if you know what you're dealing with as a patient, then the health promotion team can work on that. All right? The next barrier, now, practical access to healthy food. This was a barrier. So the first one was a facilitator, right? Because it helps you with your diet because you understand why. This was a barrier, practical access to food. The most consistently cited barrier was the cost, availability, and seasonality of fruits and vegetables. This is no secret to those of us in the room or listening to me online. Fruits and vegetables sometimes are in abundance, sometimes you can't find them. That is the reality. And the persons who are trying to adhere to this diet clearly said this. And in some instances, even when they're there, they were difficult to have because of the cost implications, right? So participant number 3 said the common man can't afford fish. Skills and self-efficacy was another domain that popped up. People were very proud to say that they grow their own peas and they grow their own seasonings and stuff like that in their garden. This we see as a facilitator. If you can start people being more comfortable growing certain things that we're saying to them, you want me to eat more spinach? Maybe I should be planting the spinach. You want me to eat more peas and beans? When's the last time you saw a long line of pigeon peas on somebody's border? That is how I remember growing up as a child. Almost every yard had pigeon peas. I'm not sure I see that as much as we used to. But if you know that this is one of the things that is a healthier part of your diet, then here is a facilitator, because people are acknowledging that. They were telling us that they understand this. On the other hand, though, the labels came up as being difficult. One gentleman, participant 9, says, I only read the label to check the expiry date. Statement of fact. Person did not understand the rest of the label, but at least they're starting to read the label. So in my mind, it's a barrier because I don't understand most of it, but it's a facilitator because At least I'm looking at the can. So what's the opportunity? Start teaching them how to read the labels. Cultural practices. Trimming fat while cleaning chicken. You would be amazed, as I was, to learn that there are parts of the world where this is not done. You go to the supermarket, you buy the chicken, you carry it home, and you put it in the oven, or you put it in the pan. So one of the things that most of the people we spoke to were able to say, yeah, but if you even eat in the fatty, whether it's chicken or pork or whatever, they trim off the fat. This is a good thing. In this, it's, you know, it's a traditional practice, but it is also a traditional facilitator. I don't think my colleague would mind if I shared with you that where he's from, he found this absolutely fascinating because he's from another culture, and he said this was not something that he had ever heard of. You bought the chicken or the meat and you cooked it with its fat. That's what it came with. So for us, this is a facilitator that we can build on. And don't assume that everybody else is doing what we're doing. Then the taste. That's an issue. I said white rice about 2 times before and I saw a couple of foreheads wrinkle versus brown rice. Because brown rice don't taste good to some people. Some of us have never tried brown rice. Why? Because that's not what you grew up eating. So the opportunity is there. If you're accustomed to one thing, I've said to people, have you tried brown rice? No, my mother never gave us brown rice. So the ability to try it now seems so remote. And so it's too hard. Have you cooked it? No, but they say it's hard. Here is an opportunity to encourage people to try it. If you don't, maybe it's how we cook it. Maybe I don't know how to cook brown rice, but somebody has to teach me, yes? So drinks without sugar, remember we said don't add sugar, have no taste at all. Again, it's an acquired thing. Readiness to change, I think is the theme number 5. It was clear there is a readiness to change. The majority of the persons we spoke to said, takes a lot of discipline, but I'm willing to try it, but I just can't afford it. And one comment I thought, which was really poignant, is it's better to spend the money on the food than give it to the doctor for the consultation. So as expensive as the food is, I prefer to spend that money than to turn around and give it to the doctor. So having said that, clearly there is a readiness to change, but we have to facilitate that change. All right? So we asked them also in the interview, so what do you suggest? Do you have any suggestions how we can improve this? And this is what they said, some simple actions and tools. For those who had issues with the charts, maybe we need to have our own some little charts that say, eat this, don't eat that. Or eat more of this, similar to what we had here, but have them available for the people in the public. You could eat this, but you should reduce this. They say, well, intensify the radio programs and town halls. This is not us, this is what the 16 people said. They want targeted assistance to offset the cost of fresh food. Recognizing the gap between the prices and so on. This brings me to flagging one conversation that has started before I exited the primary healthcare program, which I think we need to start again and continue, where at least one supermarket had expressed a willingness to partner with us. So the same way they have the loyalty cards, you know, at least 2 supermarkets, I think, on Montserrat now, you have a loyalty card, so that when you go, you get points. One at least had started to indicate a willingness to tie that loyalty card to healthier food options where you would get more points for your green vegetables than you would get for, say, the white rice. Like I said, the conversation never got completed, but without checking with that individual, I'm almost certain that he's still willing to have the conversation. And if one starts, then others will also. Right. Ivor? Right. So, in conclusion, residents are motivated to eat well, but they face certain barriers. All right? Access, because if you don't have the things in the supermarket or the guy on the side of the road or in the market or in your backyard, then there is a challenge. Education, or literacy of food labels, is another thing, because if I don't understand the difference between 2 cans of, I don't know, two bottles of sauce, for instance, which is the low salt content, the low sodium and the high sodium. You may have one, but one would be better. And thirdly, and cultural things that include traditions we also use. So we're accustomed to trimming the fat, maybe we should be promoting that more. We're accustomed to eating rice and peas. The peas are good, so encourage that more. And if you've ever been to certain places like I have, and you see what they're cooking for rice and peas, you're like, that's not how we cook rice and peas. When you're cooking rice and peas, we're cooking rice and peas, right? There's lots of peas. There are other cultures that you could count, you could count the peas in the meal. Perhaps we also have to take the reality into hand that because we have different cultures, we also have to be encouraging them to increase the peas portion of their meal because it is for their own good. And so finally, I just want to acknowledge our 16 respondents. As I said, there were 16 persons who took part in the study. We thank them very much. I want to acknowledge our colleagues at the United Kingdom Health Security Agency who provided funding for my colleague Bill Berners-Lee, who some of you may recall, who was part of the facilitating team, the colleagues at Keele University who did that transcription, and as I explained to you, the verbatim, word-for-word transcription, Mrs. Nadine Jubri, our family nurse practitioner, who was part of the team that helped to analyze the data, and Bill, as I said. And just end on the happy note that we were very pleased that our study was actually published in the British Medical Journal of Public Health a few months ago, and it is available online. It's got the barcode, and it's a big deal to get your studies published in that particular journal. It means that they accepted that you conducted the research in a rigorous way that meets the standards of international concern. So thank you, ladies and gentlemen. Do you have any questions? I can go back to my seat then. Thank you.
Okay, so I think no questions, no comments means that she has done such a brilliant job that everything is very clearly explained and we all understood. And I would just like to give Dr. Dorothea Hazel-Blake and team a round of applause for such a presentation and the fact that it was published. That's really an exceptional thing. So can we give her another round of applause for that? And some takeaways that I would like us to get. I did a training, I was helping facilitate, but I was learning at the same time. And Mrs. Minerva Taylor Benjamin, she was there, and she spoke about a lot of these barriers in terms of taste. It takes 2 weeks for our taste buds to adjust. So as you make small changes and cut back on the salt and the fat and switch into the brown rice, you know, it's going to take 2 weeks, and then that is going to taste absolutely normal. I just want to also put a plug here for the Healthy Caribbean Coalition. They are very much campaigning for front of package labels to help address that barrier where persons don't know how to read food labels or they are confused. There was a petition up online, so you can Google them, put your name on that petition, because there's strength in numbers. We are small as Montserrat, but we are a lot more powerful as a Caribbean region, so you can sign on to that initiative as well. And I also want to welcome the Honorable John Osborne, Minister of Agriculture, and I think he came in at the perfect study where we were talking about fresh foods and availability, and I know his ministry is working quite hard for that. So can we give the team, barriers and facilitators to adherents to the Dash Diet on Montserrat one more round of applause? Great. Okay, so our next presentation will be a virtual presentation, and it is being done by Lydia Robson. Just to let you know who Lydia is, she's a public health improvement specialist with Leeds City Council, and she came to Montserrat through an NHS fellowship placement, and her work here supported public health initiatives, particularly the development of a self-management program for people living with both hypertension and type 2 diabetes in Montserrat. So you'll pay rapt attention to the screen, you'll hear her voice, and while she's not here for a Q&A, we can have a discussion among ourselves based on her presentation.
Hi everybody, thank you for joining my session. My name is Lydia Robson and I'm a health improvement specialist in the UK. I've recently spent 3 months working in Montserrat as part of the West Yorkshire Global Fellowship and like to talk today about my project on empowering people with comorbidities, introducing a self-management programme for hypertension and type 2 diabetes in Montserrat. So in this presentation, I'll give a brief overview of what the Global Fellowship is, a little bit about hypertension and diabetes in Montserrat, about the self-management programme, its outcomes and sustainability measures, and recommendations and reflections going forwards. So the NHS West Yorkshire Global Fellowship is a 6-month fellowship managed by the West Yorkshire Integrated Care Board and funded by NHS England. It's primarily around leadership and quality improvement, and I'm based myself in Leeds Public Health, so I was eligible to apply and very lucky to spend 3 months in country in Montserrat with colleagues there. So a little bit about diabetes and hypertension in Montserrat. So of the 1,299 people seen at the community clinics between April 2025 and January 2026, 46.8% of patients had hypertension, nearly 8% had type 2 diabetes, but 45% had both conditions. So this is a huge health impact that faces the island. A huge proportion of people using the community clinics have at least one or both of these conditions. So in terms of their impact, hypertension and diabetes were the second and third leading causes of hospital admissions in 2021 and 2022, the leading cause being births. But in 2022, 33 people were admitted to hospital with diabetes, which made up 7% of total admissions for that year. And similarly for hypertension, this was 6%. So hypertension was also the joint leading cause of death in Glendon Hospital, making up just over 10% of annual deaths in 2022. So something that's really impacting the health system. So in my first few weeks, I spent time talking to a range of healthcare professionals to get their opinions and to start coming up with ideas for my project so it would be relevant for Montserrat. And something that really came through was quite a strong reliance on healthcare staff and a lack of personal responsibility in some cases for people's care in all sorts of contexts. And it was reported that people often choose to stay in hospital perhaps longer than they need to because, well, one, they're looked after so well by the nurses, which is really brilliant that the care is so excellent, but that's going to have problems for the system. And I was trying to explore what people's barriers to healthcare might be as well. And some of the barriers that may come to mind for the UK, so sometimes for us there are issues in terms of transport and getting to hospitals and clinics. That didn't necessarily seem to be the case in Montserrat. But there were lots of positive examples of community engagement going on already, and work happening with faith leaders and workplace health checks, and some really great initiatives to encourage lifestyle changes such as step challenges and getting people walking, which is really brilliant. However, something that the professionals shared was a lack of follow-up following any kind of screening and behaviour change interventions, meaning that they're not sustained. Also some issues, this is all kind of generally underpinned by low health literacy and not being able to understand health information necessarily. Similarly, from the public's perspective, I placed myself in the waiting room at St John's Clinic and spoke to some patients to see what their views were as well. And it was really clear there were lots of misconceptions feeding into that health literacy point. So a really strong belief in natural bush remedies as an alternative to medicines, and people not taking their medications as prescribed. And people shared that lifestyle factors, so having a healthy diet and being able to exercise, were barriers to staying well. But they explicitly stated that we want more prevention. So it's something that people are really keen for. So taking all this into account and taking into consideration previous and current work already going on in Montserrat to support other areas around non-communicable diseases, I saw the opportunity for a community self-management programme as a way to prevent and reduce long-term conditions, strengthen health promotion in the community and improve health literacy. So there have been a couple of previous programmes in Montserrat, from my understanding. So a few years ago, there was a 12-week diabetes programme, but people felt this was too long and too in-depth. So there were quite low retention rates. And similarly, there was a previous hypertension programme, which was really well received, but there was unfortunately no capacity to repeat the course at the time. So therefore, my project aimed to increase participants' knowledge and self-efficacy, so people's levels of confidence and ability to be able to self-manage their hypertension and diabetes. I also wanted to test the effectiveness of a joint programme that's sustainable for people with both conditions, rather than an individual one for each condition, given the high comorbidity prevalence and the shared risk factors and lifestyle recommendations for the two conditions. So these were my programme's objectives. Essentially, I was aiming to increase people's confidence and skills to manage their conditions and increase people's understanding of their medications, how to take home blood pressure and blood glucose readings, how to adjust to healthier food choices and incorporate more physical activity into their lifestyles, and learn stress management techniques and how to take home readings, as well as build that suite of resources for any future self-management programmes so it's more sustainable going forwards. So the self-management programme itself consisted of 3 two-hour sessions held at Braids Arts and Education Centre. It was held after work, so from 5:30 p.m. onwards, for people to be able to attend and not have barriers of work commitments. It was a targeted approach, so the nurses invited people that they thought would be most likely to benefit, as well as it being promoted on the Talking Health radio show more widely for people. So in terms of the very first day of the programme, we had a programme introduction, so gave a welcome and overview of what the 3 days would consist of. Everybody completed a quiz and self-efficacy scales for both hypertension and diabetes right at the very beginning of the programme, so that we could see if that might change by the end. So for the very first module, we had Dr. Skerritt delivering a session on understanding hypertension and diabetes, just to give that general overview and introduction. And for the second module of the day, we had Penny talking about medications. So from a pharmacy perspective, being able to understand medications, and people were able to ask any questions that were relevant to them. For day 2, we had healthy eating. So Minerva, the nutritionist, spoke through healthy eating and how to incorporate small changes into your life. And then we had a session on physical activity, so again, led by Penny. So really valuable, and we had a brief chair-based exercise as well as part of that session, so put it into practice, which was really good. And on the final day, we had 2 more modules, so stress management by Dr. Bam and self-monitoring by Nurse Dewberry. So really brilliant practical sessions. People could try out the blood pressure machines, and also at the end of the programme, people were given blood pressure monitors and blood glucose monitors, as well as some testing strips. For the programme close, everybody repeated the quiz and the self-efficacy scales again. They completed a short feedback form. We gave out information booklets, which were created bespoke to this programme. So they included information that was covered in the sessions and lots of space for people to write their readings in the back and share that with their nurses and doctors and health professionals. And everybody received a certificate as well. So this is a group photo, everybody with their certificates. So really pleased, really proud of all the participants who came along. So like I mentioned, everybody received one of these information booklets, which had information on living well, how to take and understand readings. So basically all the key information from the programme, so people didn't have to take too many notes alongside the sessions and could actually concentrate and be fully engaged. But also lots of space to write down home readings to be logged each day and shared with health professionals. In terms of outcomes then, the project successfully met its aims as shown by people's high engagement levels, their improved knowledge and improved self-efficacy, and I'll briefly go through each of these three in turn. So 8 participants attended the programme, so 75% attended all of the sessions, which was really brilliant to see. I know we're looking at quite small numbers, but we were working with a much smaller population and we wanted the sessions to be as engaging as possible and allow that time for group discussion, so it did work really well. All of the participants set at least one personal goal at the end of the programme, so showing that engagement post-programme. And on a scale from 1 to 10, they were asked if they found the programme enjoyable. The mean rating was 9.8 and 3/4 of them rated it 10 out of 10. So really pleased with those outcomes. In terms of improved knowledge then, so looking at the pre-programme quiz compared to the post-programme quiz, which was exactly the same questions, people's scores increased. So on average, it was 7.7 out of 10, which increased by 1 point to 8.7 out of 10 at the end. So it was only a 3-day programme, so I was really pleased to see improvements considering it was such a short course, and the ranges increased as well. So on average, people showed a 10% increase. And then similarly in the feedback form, just to kind of cross-check these results and see how people felt as well as just their scores on that quiz, people were asked to rate if they felt they had learned new things on the programme from a scale from 1 to 10, the mean rating being 9.4 out of 10. And then after only 3 days, 100% of participants showed an increase in the diabetes self-efficacy scores with an average increase of 26%. And similarly, 80% showed an increase as well in hypertension self-efficacy scores with an average increase of 45%. So again, really positive improvements after just 3 days. And on a scale from 1 to 10, people were asked if they felt more confident to self-manage their conditions after completing the programme. So the ratings range between 8 to 10 out of 10 and a mean score of 9.4. So again, really positive. We did produce a short video, which is on the next slide. I don't think it's going to show, unfortunately, in this recording, but I can include a link to the video, which is held on YouTube. So you can watch that at your leisure if you wish. But that just shows participants' experiences and what they got out of the programme. So I would really recommend giving that a watch. In terms of professional feedback then, so it was really important as well to capture the experience of the health professionals who really kindly gave up their time to deliver this, both in preparing the slides and preparing their sessions and also coming along in their evenings to talk to people about their conditions. So 100% of the staff involved rated their experience as either very positive or positive, so that's really good. And they also felt confident that people gained knowledge and confidence to apply what they'd learned in their daily lives. Half of the respondents thought the programme should be repeated once a year, and half thought it should be repeated every 6 months. So that's something to consider going forwards. How often do we want to repeat this? Where's the capacity? Are we able to do this? Do we want to keep it really small, tailored groups? And how often should it be? But there was real commitment there to repeating it again. The only barriers that were expressed were around time pressures, essentially, so unavailability and time commitments. But perhaps if this is something that's planned well in advance, it's something that people can build in to the programme to support people with long-term conditions. In terms of sustainability then, again, didn't want this to just be something that lasted for the 3 months that I was in country, but wanted something that could be reused and repeated in future. So attendees and the professionals showed a real commitment to having further rounds of the programme, which is brilliant. The resources that were produced as part of this programme can all be reused again. So the slides and the course content, any of the quizzes and the self-efficacy questionnaires, the feedback and consent forms, and all those resources are shared with the health promotion team, so they can be reused in future. I also presented a similar presentation at Nurses Week this year, where we received buy-in from the CMO, Permanent Secretary and Minister of Health and Social Care, who all seemed very on board with the project, which was really lovely to hear. Similarly, the information booklets as well, we're hoping they'll be printed professionally and can be shared with all patients presenting with either hypertension or diabetes or both in the community clinics and at hospital in future. In terms of recommendations then, so I would recommend to repeat the self-management programme at least every year, so every 6 to 12 months, but depending on capacity, to reach new community members and reinforce messages, even if people have been before. I think it's still valuable. I would recommend further engagement with community groups, including churches and youth groups, so we can have that earlier prevention and have that broader dissemination of the programme's self-management messages. I would also add into that to teach community leaders, so it could be faith or youth leaders, to deliver the self-management programme themselves, so reducing that reliance on healthcare staff and be something that's more sustainable and community-led, but have that support from staff to have the kind of clinical input and be able to help them to know the content and share that themselves. I think it would be good to continue to target small cohorts of people, as it was really interactive and enabled the sessions to be more personalised, more in depth. And if you had several smaller cohorts, perhaps they'd be less expensive but run more frequently. It's just something to consider. However, I would consider broader invitation methods to increase the attendance of younger people and men to reach a more diverse mix of people, and again, encourage some of that earlier detection. Post-programme, attendees felt most unsure about how to manage stress. They still showed improvements based on the feedback and really enjoyed this session, but perhaps that's something that can be explored in more depth in future programmes. I think it'd be important to create more time to accommodate more practical sessions. So the ones we had with the physical activity and being able to use blood pressure monitors, I think that was really positive. But perhaps more time to do things like develop personal meal plans, that could be really beneficial. It would be good to send personal reminders on the day for participants, so it could be via WhatsApp, just as a reminder to increase that participation and attendance. It would also be really positive if this could facilitate an ongoing support group amongst participants, so having that peer support and being able to help each other to learn tips and techniques to be able to self-manage in a better way. And there's also the possibility and a recommendation there about referring people to counsellors to enable that behavioural change if appropriate, and using the services that we've got available. So in summary, this was a novel joint self-management programme for people with both hypertension and diabetes, and it was really successful in terms of the engagement, increased knowledge and increased self-efficacy to self-manage conditions. There was really positive feedback from both the attendees and the professionals involved, which highlights the need for further regular self-management programmes. Thank you very much for listening. If anyone has any questions, do feel free to email me or get in touch, and I'm very happy to continue the conversation around this. Thank you very much.
Okay, so as I mentioned, Lydia is not with us today, but we do have the opportunity to have some discussions around what was done. She had a number of recommendations for us, and I was part of helping with this project, and part of our challenge was getting persons to come out. So we invited just over 30 persons, I believe, and we ended up with 8 persons showing up, and this was with nurses making phone calls and talking to the clients, and we still just ended up with 8. So any thoughts on how we could improve participation, because there's clearly a need for it given our high numbers of persons living with non-communicable diseases in Montserrat. Any thoughts on how we might be able to get persons to come forward and be a part of this? All right, so no thoughts, one thought.
Good morning, everyone. Dr. Scout here from the district clinics. So in terms of getting more involvement, I think what we can do is to throw it out to our patients on a regular basis to ask them, how do you think you're doing? Are you doing well? Do you have any concerns and so forth? And then we can identify persons who may need assistance more than some others. Because right now what we do is just look at our list of patients and then we would say, okay, let's pick this person, that person. But maybe those are not the persons who would think they need help. So we can throw it out to them, to the patients directly, and see who would do some self-reflection and say, yes, doctor, or yes, nurse, I think I would need some help. Please sign me up for this course.
Yes, because the method that we use, we looked at the register and we looked for persons who really over time you can see they're struggling, they're having a challenge, they're not meeting their blood sugar goals and their blood pressure goals. So those would be the ones you think most in need of support, so those were the ones that we targeted, yes.
I agree with Dr. Scarrett. Instead of just looking at the numbers, you got to look at where the people are in their heads. Because whether we like it or not, there are still a very large group of people who think that their diabetes or their hypertension is something that doctor and nurse is going to manage for them. That is why they come to the clinic. That is why they make, and these are some of the people who come every 3 months on the appointment because doctor is going to help me manage my blood pressure or my diabetes. We need to start getting them to change that mindset to understand that this is a chronic condition that you have to manage. And it's not their fault. It is how medicine was practiced many, many years ago. The doctor told you what to do and how to do it, and the nurse told you X, Y, Z, and you obeyed. So it's a whole new mindset to understand that. You see this condition, it's mine. I am the person living with it. These people are going to help me, but I have to learn to manage for myself.
Mm-hmm. I see.
Yes. I think also in terms of engaging persons to be part of the exercise, I think the Ministry of Health need to reach out further from themselves. In other words, there are groups. You have the Montreal Diabetes Association. You have other groups out there that you can ask their membership to participate in the process. So I think reaching out would make a difference in terms of getting a larger number of persons, but obviously persons who would have an interest in their health.
Thank you.
Good morning, everybody. I agree with Mr. Howe. That's exactly what I was coming to say. And as well, I remember when I started nursing initially we used to have the sessions where patients would come. You have hypertension and diabetes clinic. You have a group of people coming there. And then you would use that opportunity to have sessions with the patients. So that's something that we can think about going back to try to, because maybe the time of the day too is an issue. That persons at 4 o'clock, 4:30, it's time for me to wind down and go home and rest. So I'm not going to come at that point in time. So if they come into the clinic, we have a cohort. Maybe on a Wednesday at Coacherhead when we have clinic, we say, okay, we have 20 people coming because they do make the appointments now. So we know who's coming and we can schedule to have sessions there with them.
Yeah, good morning, everybody. This is Dr. Valentine here. Okay, I just want to add to what they have spoken about. Now, I've been some time in Montserrat, and I've had an observation. We have tried several things. Some worked, some didn't work. But I think the major thing that we need to concentrate more is communication. It has to be a constant process. Now, all of these chronic diseases we're talking about is a progressive thing. And over time, people you find out that they continue, they deteriorate, and they further continue with more medications and all of that. So the engagement, it's multifactorial. Just like Mr. Howe said, all the bodies have to come. But again, we have also realized that sometime we had a drive and tried to pitch persons to come to the sessions. in the district clinics, but the outcome was not very, very something welcoming. The first day, and before you know it, everybody lagged away. So I think it still boils down to a constant communication, constant engagement, constant education. Now, a lot of people want you to own responsibility for their own health, which is a very wrong thing we should change. And that behavioral change has to cut across all paths, because all moving parts from what brings people to getting better health. That education must start with what you eat. Very, very important. How active are you? Yes, some people have more tedious jobs than others, but again, we need to begin to understand how our food and our gut plays a major part of everything that we become. Because over time, people don't realize that, okay, this goes down the line, you're hypertensive now. Some would say you never go out of the medications. That's wrong. It all depends on how you are self-efficacious to do what? To understand what you need to do and begin to implement that at your own lifestyle. Yes, we can do all the education we want, but the truth is, if persons are not taking responsibility for their health, then it's a no-no. So I always try to look at this approach. One-on-one encounters in those consultations, very key. Yes, we see that the standard of care practice doesn't allow you all that frame. Sometimes you just have to be 20 minutes because you're also looking at other persons that are coming into the clinics. But again, that engagement has to continue. We are doing, there's a new drive upcoming. Well, maybe that is a way. Talking Health is doing the same things and all of that, but it's a continuous thing that has to continue. People must begin to understand, pay attention, and do the needful. Thank you.
Thank you. I think maybe there might be room for us to start considering counselors, coaches that can help our clients to come to that level of understanding that there needs to be ownership, quote unquote, ownership of their health, and they need to be active participants. We'll take a last comment from Dr. Imara, and then we'll go to the next presenter.
Thank you, Penny. Dr. Imara here, clinical psychologist. Penny, you've just touched on exactly what I'm about to speak on there, so good timing. I think the government needs to consider the addition of a useful member of the multidisciplinary team, health psychologist. I think we need one for these patients. So if we were to have a health psychologist, they would be able to offer the necessary ongoing psychological support to these type 2 diabetic clients and hypertensive clients as well. So I think they're very much a missing part of the MDT that we need to consider as a country adding. They will be able to help with the goal setting, addressing the psychosocial factors, and enabling behavioural change ongoingly. So a referral to health psychology as part of their care plan, I think, will fill in some of the gap here that we're discussing today.
Yes.
That's my commentary.
Thank you. I see one person with a burning question, so this is the very last, and we'll get to the next presenter.
Kimona Daniel Bourne, Senior Medical Technologist. It's not a question, but it's just to highlight that whatever we do needs to be more patient-centered. Because based on my experience in the laboratory, patients come and it seems as though the system is very robotic. So the doctors tick, 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 and then the patients come and ask, what is this test for? Why am I doing this test? So as Dr. Valentine says, there might not be a whole lot of time at these consultations to, get deep into what is happening. But whatever it is, we have to correct that robotic, mechanistic way, and it has to become a lot more patient-focused, and for them to be able to understand what they're doing so that they can actually manage their condition. So they should know, I have a 2-hour test and what the 2-hour test is for, as opposed to, oh, I don't even know I have a 2-hour glucose test. So whatever it is has to be more patient-centered, and it has to be less robotic, just from the laboratory's perspective.
Thank you. Thank you guys for that very robust discussion on this topic. Hopefully we can put into practice some of what we discussed for better outcomes, patient-centered approaches. A health psychologist is above us, but we can do our best to try to encourage and coach at every single level so that our clients feel more involved, more part of their own healthcare, and would have better health-seeking behaviors and receive our support better. At this time, we are going to have our next presenter by way of Nurse Donique Lane. She is the acting community mental health nurse within the Ministry of Health and Social Services, and she is going to present on mental health presentations in Montserrat, a 6-year review of diagnoses, referrals, and service use.
Good morning, everyone. I am a very short lady, so I will adjust. Thank you all for having me. This is my first time presenting at Research Day, and I am very thankful for the opportunity to be here and to share with you some information that we would have worked on over a period of 6 years within the mental health department through data collection. And Mr. Bam would have presented, I think, last year, or in 2023, I think, he would have presented the first 3 years of data that we would have collected. And I'm here to give you the latter 3 years, which is from 2024 to 2026. And we're going to also look at how things would have changed over that 6-year period, what's new, and how this data impact the way we provide service. Yeah. So we're going to basically look at the background in terms of how mental health care is organized in Montserrat, the aims and objectives of this study, what the results show, and how things would have trended over that 6-year period. And of course, we will also look at some of the results from an episodic level and in terms of strengths and limitations and what we can do going forward to strengthen our service. Okay, I think, is it me? Oh, yes. Be patient with me, please. All right, so Montserrat is a small island, and of course, like any other part of the world, there are certain challenges that we encounter when it comes to mental health. Stigma is not a new word, and of course, we know because of our smallness, we are more or less considered a community. That makes it a bigger challenge for us in terms of how, mental health is being stigmatized. And it's a real barrier for us in Montserrat. But on the flip side, we can look at things and see that because we're a community and we're so small, we also have that protective factor where we look out for each other and we share and we try to always be there and to, give that helping hand to the next person. In terms of our current service model, we are community-based, fully community-based, and our central area is St. John's Clinic. Our team consists of 2 clinical psychologists, one for adults and the other for children and adolescents. We had a clinical counselor, but that position is no longer filled at the moment. We have a community psychiatric nurse acting, which is myself, and we currently have a prison nurse on staff. She's a staff nurse / prison nurse who works directly with the prison service because we've now introduced health within the prison system where we offer certain health services to include physical and mental health to the prisoners without them having to be going to the different health centers. So we have taken the initiative to bring health care within the prison system. We have a consultant psychiatrist who generally would visit on a quarterly basis for a week to conduct psychiatric reviews and evaluations. However, she also does virtual sessions on a weekly basis when she's not on island. We also do proactive outreach programs such as screening. We know all of the health centers, the nurses usually go out on a quarterly basis to do screening within the workplaces. Mental health has also incorporated an aspect within that program where we also do mental health screening. And from that, we're able to pick up early on conditions or maybe situations where persons require our support, and we're able to give them that from a very early stage. We also participate in weekly radio programs where we have Enhancing Your Mental Health on a Friday mornings. I'm sure all of you would have heard it at some point in time. And our inpatient situation at Glendon Hospital, it's not the best at the moment. However, we do have some form of accommodation, a room where if we do require to have a patient admitted, that room is where we use to have our clients admitted, and we treat them and of course prepare them for transition back into the community. Good. So what this review sets out to do, I am not an epidemiologist. I am not good with data. However, we're hoping that from this, we're able to give something so that the policymakers, the high-level managers can see what's happening in mental health and use that information to plan for the future so that we can improve and grow and be better at the service delivery, specifically for mental health. And our two main objectives, the first one is more descriptive and it focuses on who we see, such as the clients. And objective 2 is about the change that would have happened over time. And as we go along, you will get to understand more about why we would have separated the two. Right. So, data source and analysis. Quickly, this study population is basically clients who we would have seen within our clinics. So these are persons who actually came to us at mental health. We did not include anyone outside of that. This is just based on persons registered with the mental health service in Montserrat. Data was collected basically from a data spreadsheet that we've been updating over time. As we get new clients, we update that spreadsheet. We take all the necessary information, and we have that. And of course, the storage and analysis of data is in accordance with the General Data Protection 2018 regulation. And we classify the diagnosis of each condition that we would have seen based on the DSM-5. And of course, those without a diagnosis are classified as psychosocial or functional concerns. Sorry. Is it me that don't have? Right. So I won't focus too much on the numbers that you see on the screen, but briefly, our service, for the size of our service, we've been managing a patient load of over 400 patients, and we've had over 400 episodes across the 6-year period. And for each episode, it's diagnosed via a structured clinical observation and interview process. So once a person comes to us for the first time, our first assessment would have been clinical observation and interview, where detailed information is taken from the client, and of course you observe their behavior, what they say, how they do things, and how they respond. As you can see, there's a 21.1% screening figure that basically looks at the supplementary screening tools that we would use within our service to accompany our interview and observation as part of our assessment tool. It is not necessarily a figure that says it's the only measure that we use, but it's just to show that along with the observation and interview, we also use other assessment instruments and tools to confirm a diagnosis. In terms of demographics, we can see that there is an almost 50-50 split in terms of gender, where there is 203 females and 202 male patients overall. I know I would have said that we have a caseload of 400, but at some point you would have seen a number of 400 and something, which is a difference of 8 patients. I'll explain to you later on why that difference is there. The median age is around age 27 years at first presentation, and the peak age group that we're now seeing is from 10 to 19 years, and this is the single largest band for both sexes. And I want you to understand that the reason for this is not that we're seeing more children, it's that since we've had the addition of a child and adolescent clinical psychologist, we are now able to capture this particular age group within our mental health service. Right, so 413 episodes of illness recorded among 405 patients, which is an 8-patient difference. Now, this 8-patient difference means that there are some persons who would have been recorded on the roster twice because they would have been seen at 2 different times in terms of year, and they came in with 2 different distinct diagnoses. So they're accounted for as 2. They're repeated in here as 2 different persons. Yeah? So that's why you're seeing the difference in the 400 and the 413 figure. Yeah? Okay. So as we look at this diagram, we can see for descriptive and psychotic disorders, these remain the 2 leading illnesses within mental health that we have been seeing. It's consistent with the data Mr. Bam would have presented in 2023, where those were also the 2 leading mental health conditions presented within mental health. Behavioral concerns and neurodevelopment disorders are now also a meaningful share as well. And as I said, these are as a result of the fact that we are now able to assess these children properly and formalize their diagnosis, so we're able to put them in and account for them properly within the data set. We still see a lot of acute presentations. Of course, anxiety, depression, trauma-related disorders, bipolar also, is not a large number, but it's still significant. Substance abuse disorders as well are coming up, behind quite close. So this gives you an idea in terms of the breakdown of diagnoses and the numbers, so you can see where our majority patient falls within the different diagnostic levels. Okay. So females, if we look here closely, females are more, you see a lot more, they rank higher when it comes to depression, anxiety, and trauma-related disorders. So if we're to do screening or outreach, this data basically tells us where we need to put our focus more. So if we want to capture, the persons with a lot of depressive symptoms that we see, we need to screen a lot more females, because this is showing where the number increasing more versus males. We're not seeing that high number in males. We're not saying that it's not there, but more females are identified to have depression, anxiety, and trauma-related illnesses. Versus the males, we are seeing more of them in substance use. Yeah, we're seeing a lot more of the males in substance use. And, well, of course, for the neurodevelopmental and behavioral, those are for the younger males. And of course, psychotic, we're seeing a lot more males. And of course, the reason for the psychotic and substance use, the two of them most times go hand in hand. So we will see a male that has a psychosis and also has a comorbid condition where it's substance use disorder, which contributes to them having the psychotic disorder. Right. So this figure is a bit dense, but I want you to not focus too much on all of the fancy gibbery that you're seeing there, but also just to show that the diagnostic lag for anxiety and depression disorder in women with onset happening well before diagnosis. So oftentimes when these persons are diagnosed with anxiety or depression, the onset would have been way before. So when you take the history and you interview them, you find out that these symptomology would have started maybe a few years before, but it was never picked up. Yes? And of course, going forward, we're hoping to improve on that by doing screening within the workplace where we're able to identify stressors early and intervene at an earlier stage so that we can prevent them from when they do come to us, that we're not seeing them when the disease is already progressed. Yeah? In contrast with trauma-related disorder, which presents quickly after onset, and of course this has a direct link. We know that the trauma is related to something that actually happened, a physical event that would have happened in that person's life. So we're able to link the onset of trauma-related illness to an event versus the depression where you're not able to determine, what would have contributed to it or what would have caused it. Yeah, so it's more identifiable for us to say the trauma of X person is as a result of maybe a car accident or some childhood-related situation that would have taken place. Psychotic and substance use disorders are present across the board, across age range and extending further into middle age, particularly among males. So we have to pay attention to our males. I know as females, we're very quick to go to the doctor. We're quick to pick up the phone and say, listen, something is not right. I'm not feeling okay. And our males are very resistive. They prefer to say, this is going to pass. I'm going to ride this through. And then when they do come to us, it has been so far progressed that it takes a lot of work to get them over that hurdle. So we need to do a lot more screening and involve our males and encourage them to participate and reach out the moment they feel or they can sense that something is not right or they don't feel right within themselves. Have a conversation with someone, and don't wait before it gets too late, because early intervention can prevent it from becoming something that you don't want it to be. Yes? And of course, recovery is much, much easier when you intervene at an earlier stage versus if you wait until later on. The recovery process is longer and sometimes it is even more difficult for that individual. Right. So episodes of illness over time. If you look on the chart, you'll see that there's a 1976 year there. I want you to let that sink in for a bit. This shows that we actually have a client in our system now that would have had a first contact since 1976. Think about that for a moment. Since how many years? 50 years. And that person is still within our system as an active client. Yes? So over the years, you can see that the numbers have been relatively low because we do not have a lot of data. It's not that the client numbers are low in that we didn't have a lot of clients back then in those years. They were, but they're just not enough record to prove it. So we don't have enough data to go back as far back as, 1976 to get all of the information to say we have X amount of clients during that period. It's relatively higher than what this is showing, but it's just to show you that we actually have persons in our system as far back as that year. And when you come closer to 2016, 18, 2020, you realize there's an increase. It's not that we're seeing a lot more new clients. This is when we've actually started focusing on collecting the data, and the data started to show that we have a lot more persons in the system than we actually thought. Yes? Of course, there have been over the years new persons coming in. The numbers are, well, I wouldn't say too high or too low, but it's there. However, this is just to give you a snapshot over that time period, what the data looks like in terms of clientele. 202 unique patients account for the 246 study period episodes. And where you see 238, this is where new patients accessing service for the first time. Yeah? Here, a broad diagnostic mix over time. We were only able to compare depression and psychosis because these are the only two diagnostic conditions that we actually had this amount of data to be able to compare side by side. So as we can see, pre-study, we had about 23, and then for post-study, during the same study period, it's a little bit on the lower side. Behavioral concerns and anxiety, all of these grew by 11 to 15% in terms of episodes, and they basically fall within the psychotic disorder condition, and of course, as we go along, you will see where there's other changes in terms of numbers. New patient presentation by year. So from 2020 to 2026, we saw in 2020, we had 62 new clients. We had a little dip in 2021. It could be related to the fact that we had COVID at the time and the access to healthcare, we had to scale down, but it doesn't necessarily mean that persons weren't coming forward. And then if you notice, in 2024, we had the highest number of intake for that year. In terms of referrals, quickly, we can see here that the largest portion of our referrals came from family and self-referrals. So a lot of persons are taking the initiatives to refer themselves into the system, or their family members may see something is happening and they reach out and seek help on their behalf. And here basically just shows you where most of the referrals would have come from. And the largest number during 2024, January, came from the doctors. We're not sure why this is happening here, but it could be more and more persons went to their GP and the GP were able to pick up and refer them on to us. So this basically shows you what I mentioned earlier in terms of the diagnostic tool. Majority of our clients are, well, all of them are screened and observed and go through the interview process initially. And that 21% that you see there is what would have been use a supplementary screening tool to confirm their diagnosis. And if you look at the side, it shows you some of the screening tools, the assessment tools that would have been used throughout. Of course, in terms of treatment, psychotherapy, medications, we do have, majority of our persons who are on medications are those with psychotic disorders. We do have others who are on medication that has other conditions. And of course, CBT is one of the main treatment modalities used within our service. And this basically just reinforces that. Employment status, now I want to be clear here, it's not that we have this great amount of persons that are unemployed, it just means that we do not have the information for these persons. Because if we look, a lot of them fall within the working population, and it could be either one, they have a very severe mental health condition that prevents them from working, or we do not have the information to show that they're actually employed or not. Mental health comorbidities, this basically shows clients who have dual diagnosis, so they have a main diagnosis of whether it's psychosis, and it may be in conjunction with depression or anxiety or substance use disorder. So this is where they have more than one diagnosis. They have a primary diagnosis and then other diagnoses that would have followed. Some persons actually have 2 or 3, well, sorry. I don't know what happened there, but some persons have 2 or 3 diagnoses altogether. So here, it basically shows that we've done a very comprehensive review of the study. It's over a 6-year period. It's consistent with how we classify our diagnoses according to the DSM criteria. And of course, it's a proactive model where we incorporate screening so that we can detect early and intervene at an early stage. Our limitations, the data set, it's partially incomplete. There's still a lot of information missing, and we're hoping that over time we can able to fill those gaps so that we can give you a better picture, maybe next time if we get the opportunity in another 3 years to come and present and show you what has actually happened and changed over time. We're still small in numbers, but however, we're still able to capture a lot of relevant information and show you, what the data is actually saying. Of course, persons do access care. Care is very easily to access. We don't have too much of a rigid referral process, but we're trying our best to make things as simple as possible. Some recommendations: we want to strengthen early detection through our screening. We want to target high burden conditions. Of course, we saw where there's a lot of depression and anxiety in women. We want to ensure that when we're screening for that, we focus on our females. And when we're screening for substance use, we want to focus on our males because that's where we're seeing the higher numbers. We want to also improve our focus on children and young people. We don't want to leave them out because they're a major part of our population. And we want to, of course, address the employment impact. But again, as I said, this may be due to the fact that we do not have the information for that particular thing. So to conclude, we're small, but we do have a very large number, of course, but the diagnostic mix, burden, and new patient presentation rose about 12.7% from when Mr. Bam would have presented in 2023 to now. Thank you for your patience, and I hope the information was informative.
Yes, so in the interest of time, we'll just take 1 or 2 burning questions or comments, if anyone has any.
Thank you, Nurse Lynn, for the presentation. I am Nurse Julian. You said there are about 400 plus persons who access the service that you give, your department gives. Do they all have diagnoses, or are they just, is it included the numbers in persons who probably just going for a rough time and they would come to just see somebody just to talk?
Yes, thank you for your question. Good point. As I stated earlier, yes, we do have a range of persons. Majority of them have a diagnosis, but also there's a small proportion of clients who do not have a diagnosis, but they're there for maybe some psychological stressor, or as you say, they're going through a rough time and they just need to talk it through and stuff like that. So there is a small proportion of persons who do not have an official diagnosis. So they're also captured there. In
okay,
that
thank
data,
you.
yes.
I have another question, please.
Yes.
What I want to ask is, what are the plans that the mental health department going forward is going to implement? I've realized that, to me, from what you were saying, that the clients are mainly referred to you all, or the screening is done through workplace screening, which is organized, at primary healthcare level. But the department itself, is there any plans that you all have or going to put together to screen clients?
Well, currently, outside of what we do with the workplace screening, we don't have any major initiative going on in terms of that screening. We have started rolling out screening for antenatal clients, which the midwives should have been doing within the antenatal clinic for depression and anxiety during pregnancy. I'm not sure how well that is going, but that is one area that we've been doing screening. I think there is some screening that is done during school health where we capture the children during the school health period. We screen them for moods and feelings to see how they're feeling, and based on what we pick up, they're seen by the clinical psychologists, and those issues are addressed. So there are other little things that we do, but in terms of a major program like the workplace screening, no. Yes?
Just so, Mr. Bam, but as a midwife, I've been here for a year plus, and I have not seen that what you spoke about, the midwives doing the screening. I mean, there is nothing in particular that I have come in contact with. I mean, if I see a client who has a problem, definitely the client will be referred, but to me, there is no structure. I have not seen it either.
Okay, I guess that's something we can look into. Yes, Mr. Bam?
I can see that.
Thank you very much, Nurse Julian, for your question. Let me just address the last one you put up. My understanding shows that there has been a level of, some level of screening going on in the midwives. Maybe information sharing should be strengthened. I'm aware that the midwife nurses have certain instruments, okay, basically that they use to screen post-perinatal depression, for instance, and some anxiety. And recently, I was referred, a patient was referred to me, and I saw that the nurses have actually improved on their screening method. I saw something on anxiety, I saw something on depression during and post-natal. So I feel that is a form of screening. There are so many screening programs going on, which I'd like to highlight beyond the issue of schools health and the workplace screening. At every opportunity that we have to do health program within the community, we actually do screening. For instance, the Health Fair that is organized by the primary health care is a yearly affair. We try to do mental health or psychological screening at such program. Sometimes last year, there was an organized program about men's health that actually took place at the beach, one of our beaches in Montserrat. We took advantage to screen for psychological health and mental health. Yeah, it could get better. Once we have referral, we need to do more programs to cut across the length and breadth of our community so that we can take advantage of more screening. But almost every year, we embark on several programs that we would have done mental health or psychological screening. Thank you so much.
Thank you very much to Nurse Lane for that presentation. We are going to make a brief adjustment to the program. In the essence of time, we have to move on, but you have an opportunity that you can interact with the presenter during the break. We're going to take our break now. It's going to be just for 15 minutes. There are light refreshments at the back, fruit, nuts, some treats for you. Help yourself and take a time to walk around, have a chat, stretch your legs, use the washroom, and I will see you back here in 15 minutes. hear me. There we go. Okay, welcome back. Just to announce a few changes to the program. So prior to lunch, we were supposed to have Hayam Algebra. However, we're going to push that presentation to the afternoon, and it will take the place of Dr. Adrian Rudd, who will not be able to present today. Okay, so we're going to proceed with our next presenter, but before we do, I do have a comment coming in online, and it was actually a question the person wanted to make, but it came in late, and this was for the DASH study, the first study with Dr. Dorothea Hazel Blake, and that person was saying since it's difficult for adults to change lifelong habits, including diet, can we not use the approach of introducing healthy diets to younger people? And maybe that's something that we can think on, changing our strategies and including the DASH diets with the younger generation. Okay, so now we are going to hear from one of our public health nurses, Donalda Henry. She is going to come to the podium and deliver a piece of research that was just very recently concluded, Behaviors and Beliefs Towards Routine Adult Vaccinations in Montserrat.
All right, good morning, everyone. All right, so this morning I will be presenting behaviors and beliefs. Good morning. This morning I will be presenting on behaviors and beliefs towards routine adult vaccinations in Montserrat. This study was conducted by the community nursing manager, Alex Axie, Rosie Collin, our visiting epidemiologist from UKHAS, and Ms. Shenlea Fenton, who is our surveillance officer, and today I'll be presenting on their behalf. So just to give you an overview of the study with its aim, rationale, and the methodology used. The rationale for this study was we noticed that after the onset of COVID-19, there was a reduction in the adult uptake of vaccines within the Montserrat populace. And as such, we decided to conduct this study to find out the reasons behind this. So the rationale was to evaluate and adopt vaccination activities and programs to ensure that they are as effective as possible, with the aim to, 1, assess the public confidence and satisfaction with vaccine, 2, identify any vaccine hesitancy. The methodology used during this study was a census sampling among the clinic attendees, and we used a non-probability sampling method. The clients consisted of persons attending the health center during the month of June who agreed to, of course, participate in the study. This is an opportunistic sampling of clinic attendees rotated over the 4 health centers for the month of June with a sampling time proportional to the health center demand. So we focus mostly on the days that we expected a larger clientele among the clinics. A structured questionnaire was administered using a multi-mix choice question approach with rating scaling questions, open-ended questions to gather the written feedback from the participants. The data was collected in person, interview, and recorded on tablet using the Kahoot toolkit. So we're going to look at the data. So from the screen here, we can see that the participants consisted of 66 total respondents, predominantly female were the main participants. The age category that we captured was between 26 to 35, followed shortly by 36 to 45-year-olds. In terms of sex, we look at the historical vaccine refusal by sex, and it was predominantly found that women, about 65% of women had refused some sort of vaccines for themselves throughout their lifetime. And as again, we can see that most of the respondents were female versus male. We look at vaccine refusal by age. And among the respondents who delayed or refused vaccine, the most common age was again between the age 26 to 35. We also see that the refusal was more evenly spread across the age groups, with the exception of the 75-year-olds. Among those who had not delayed or refused vaccine, 83% of the respondents were between the age 15 to 45. And we can all say that this was attributable to the overall respondents who participated in this study. We looked at vaccine knowledge because we wanted to assess what the populace knew about vaccines. And for this, we asked, to what extent do you agree with this statement? I know what vaccines I need as an adult. They had a ranking scale to use. 1, I don't know at all. 3, somewhat know. And 5, I completely know what vaccines I need. From the study conducted, we can see that 53% of the respondents answered that they do not know what vaccines they're supposed to have, versus 39% answered they somewhat know. So we can see that there's some knowledge gap here between amongst persons who know what vaccines they should have versus what they shouldn't have. We also look at their source of information as it relates to their knowledge in terms of vaccines. So we look at friends, social media, traditional media, which includes our radio station, government messaging information system, health care personnel, international and local. From the study, we know that overall, the most common source of vaccine information used by the respondents was the local healthcare professionals. And that is 83% of the respondents, followed shortly by family and friends at 38%. Notably, though, is that the use of the government information system was the second lowest at 17%. When we look at ranking by trust level of each information source used, the most trusted, that is ranked 5th for completely trusted, were government health messaging system at 36%, followed closely by international healthcare professionals, 33%, and local healthcare professionals at 22%. Now, due to the small size, results must be interpreted in caution, or with caution. The least trusted, that is the greatest proportions of respondents using the information source, giving a ranking of 1 that they do not trust the sources at all, were the traditional media at 30% and social media at 16%. We also look at persons' beliefs. So when ranking vaccines in terms of respondents' belief, whether they were safe, effective, and beneficial, it is noted that the majorities of respondents answered 3, that they believe that vaccines are safe at 71%, effective 64%, and beneficial at 68%. We look at benefits of the vaccines. Overall, 3/4 of the respondents felt vaccines were beneficial with respect to protecting them from vaccine-preventable diseases, reducing disease spread in the community, and protecting vulnerable people. Self-protection against vaccine-preventable diseases and reducing community spread were highest at 89% and 88% respectively. They also believe that vaccines are good for protecting the vulnerable people, which was somewhat lower at 77%. So we also wanted to know what their concerns were concerning vaccines. So we look at, was it a fear of needles? Is it due to cultural belief? Is it due to a language barrier? Because we know we are a melting pot. We have persons from other nationalities here in Ireland who their first language is not English. We look at cost, but cost shouldn't be a factor because all our vaccines are free. Is it due to appointments, time constraints? So there were several factors that we look at. The main takeaway from this is, regarding concerns, the majority of the respondents have some misconceptions around the effectiveness and safety. That is looking at the long-term and side effects of the vaccines, including having reported hearing negative information or not receiving enough information for them to make an informed decision. Barriers are very infrequently reported, which is somewhat good. However, due to Montserrat being a small community with close ties, primary care shows that we are doing a good outreach so far, but there's always room for improvement. So in summary, results of the survey indicated that although persons were knowledgeable about the vaccine's safety and efficacy, they generally may have some misconceptions or misinformation about how vaccines work over a long period of time. Negative information about vaccines directly affect people's views about vaccines. And although most persons view vaccine as somewhat positive, there is still the attitude that most vaccines are not necessary, as the virus or disease are not present within our region. So in essence, there is a disconnect between the attitudes or behaviors which are negative towards vaccine overall, and there's a quite high perception that vaccines do more good and bad. So there is some disconnect. Results of the survey also indicate that although persons are knowledgeable about the vaccines and did not doubt their efficacy and safety, they generally did not see the need for the vaccine. And this stems, again, from us not having any vaccine-preventable diseases on Ireland. Most of the healthcare professionals that you speak to have never seen a case of measles, much less to other childhood preventable diseases. All right. So I'm going to look at the limitations of the study. The limitations of the studies that were identified is that we only targeted persons attending the health centers, so it's likely that they already have good health-seeking behaviors. we looked at recommendations coming out of the study, and it is recommended that we expand the research to hotspots such as community groups, churches, supermarkets, as well as doing an additional survey on a larger target population. It is suggested that the survey be carried out to assess the attitudes in respect of childhood vaccines, and we should continue to educate the public about vaccines, outlining their importance and successes over the years. And with that, I would like to say thank you for listening to the presentation this morning, and I would like to again acknowledge the participants of the study, Nurse Alex Aki, Miss Rosie Collins, and Miss Shenlea Fenton. Thank you. Any questions this time?
Okay, thank you, Nurse Henry, for presenting on behalf of your colleagues. Very useful information. I just wanted to know, though, what was the total study population for this?
66 participants.
Okay, thanks.
Thank you, Nurse Henry, for your presentation. So I was thinking about vaccinations being presented here as though they're one homogeneous group. But I'm thinking that what you're probably going to find is different attitudes and beliefs about certain vaccinations. So it would have been helpful to know which vaccinations they're talking about, as opposed to others. If you just say vaccinations, don't really know what vaccination.
So for this study, we didn't highlight any particular vaccine. We just did a general study in terms of the perceptions of persons' beliefs, attitude towards vaccines on a whole. So we didn't go into detail on each particular vaccine. Maybe that's something that we can take up.
Yeah, I think
study.
just anecdotally, when I speak to people about vaccinations, what I tend to find anecdotally is they have various beliefs which differ in their attitudes according to what vaccination is being spoken about. So you might be okay about having the flu vaccine, but not okay about having the COVID vaccine, for example.
Right.
I'm just saying.
Yes,
yeah.
I said, point taken, but as I said, we just did a general study on attitudes towards vaccines on a whole, and not a particular vaccine.
Okay, thank you.
You're welcome. Thank you.
Yes, thank you very much, Nurse Henry. And I found this very interesting, particularly as the disconnect that you mentioned in terms of people reporting, the 66 individuals largely reported that they felt it was safe and effective and good for the community, but not for me. I don't want it for myself. And I do think that fear is a powerful motivator, and we've done such a good job eliminating, maybe that's the wrong word, that's the incorrect, that's not the scientific term, not eliminating, but keeping vaccine preventable illnesses at bay, that because the illnesses are not seen anymore, it gives that lack of fear that it doesn't exist, it's not around, so I don't need to be vaccinated anymore. But it's only through robust vaccination programs is that outcome possible, and hopefully through health education, we can bridge that gap so that our adult population can understand better. So we will now hear from Fiona Brown. She's a nurse within the Ministry of Health and Social Services. She was also one of All Saints University of Dominica top performing students. I believe that was in 2024. And she is coming here to present on Her work done there, assessment of the impact of dietary patterns on the health and well-being of older adults. So please give her your attention.
Good morning, everyone. My name is Fiona Brown, and it's my pleasure to welcome you to my presentation today. Before I begin, I would like to give credit to my co-researcher, Joshua Parry. So I will be sharing today the findings on the assessment of the impact of dietary patterns on the health and well-being of older adults. Okay. So living longer is a triumph of modern medicine, but living well is a product of daily habits. Today, we dive into the powerful connection between dietary choices and the health outcomes of older adults, and how targeted nutrition can change the trajectory of aging. So here's what today's journey will look like. We'll begin by looking at why this research matters in the background section. Then we will look at the specific questions we set out to answer, how we gather our data, and finally, the most impactful insights and recommendations we discovered along the way. So, for the background and rationale, we'll look at chronic disease and its connective on it and the high rates of, we look at poor diets that drive high rates of heart disease, diabetes, and other chronic illnesses, which lowers daily quality of life and raises overall healthcare costs. So food choices may vary widely based on demographics and income. Finding solutions is critical as the aging population grows rapidly. So the research questions we're looking at today: what drives the nutritional needs of older adults? Which dietary pattern supports optimal health? How do daily eating habits impact overall quality of life? And finally, how effective are current dietary strategies at improving outcomes? So we know aging lowers metabolism, alters digestion, and shifts body composition. Finding dietary gaps improves health recommendations. That's what we're looking at today. So in our methodology section, we looked at, it's a systematic literature review using a purposeful sampling. We selected 4 peer-reviewed articles. Focus was on adults 65 and over, living in diverse situations across different demographics. 3 databases were used, namely PubMed, Google Scholar, EBSCOhost, across 3 different countries: USA, China, and Ghana. So as people age, their appetite naturally declines. These slides highlight a critical statistics, which is 30% of older adults cannot eat enough food to meet their basic needs. According to research, by adopting a diet rich in fruits and vegetables, legumes, nuts, and seeds, with olive oil as the primary fat source, this lowers the cardiovascular risk by 30% and reduces metabolic disorders by 20%. 60%, that is the percentage of older adults who completely prioritize meal enjoyment over nutritional value. Right. So, according to research, 40% increase in fruits and vegetable intake following nutritional education programs. So after nutritional education, persons started doing better, so we had a 40% increase. So we know how to improve the diets of older adults. Now we need to fix how we reach them. So as it says, mobility issues and transportation barriers limit reach for many older adults. So, for barriers to healthy eating, dental issues and reduced taste was one of the biggest outcomes. So if it hurts to chew or nothing tastes good, balanced eating falls apart. So for psychological, social isolation and depression shape food choices. So we don't just need nutritional foods, we need someone to share it with. For social issues, companionship and flavorful, enjoyable meals. So a lonely mind almost always leads to a lonely plate. For cultural and economic, affordability, access to fresh produce and cultural food traditions shape dietary choices. So healthy eating is a luxury when fresh produce costs more than fast food. So our discussion and conclusion, nutritional needs are shaped by age-related change, chronic conditions, medication interactions, and socioeconomic factors. Age changes everything. How we eat must also change with it. The Mediterranean diet remains our most proven blueprint for longevity. Balanced meals protect both the aging mind and body. And informed healthcare providers possess the power to transform lifestyle habits. Our recommendations are: encourage diets rich in fruits, vegetables, whole grains, lean meats, and healthy fats. Minimizing processed sugar and sodium. Fueling a vibrant life starts with a simple choice: flooding the plate with nature's best ingredients. That is from the farm to the plate. Healthy eating works well for older adults when the food tastes like home and their choices are respected. So strengthen family, social, and community support system that changes dietary choices. Nutrition doesn't happen in a vacuum. The strongest ingredient in a healthy diet is a supportive community. To truly measure dietary success, we must look beyond a single meal and track a lifetime of habits. Thank you, everyone. Are there any questions?
So thank you, Nurse Brown, for that presentation. I love how we all laughed a little bit when it said 60% of older adults prioritize taste over nutritional value. Why did we laugh? Because it's applicable to all of us, no? So we need to find the balance, and I want to repeat again what I said this morning, my lesson that I learned from our nutritionist. It takes 2 weeks to change our palate. Yeah, 2 weeks, and what you thought had too little salt and too little fat and too little sugar will now taste absolutely delicious. So you owe it to yourself to give yourself that 2 weeks. We have somebody coming to the microphone. Yes.
It's not a question, just a comment. I think I don't remember who said it, but it was after Dr. Hazel's presentation, where the person said, instead of trying to teach older people how to form healthy eating habits, it's better to try to teach the young ones, so then when they come up, they just, for example, with the amount of water, case in point, Stanley cups are such a in thing, and the cool water bottles and stuff. This generation, the younger generation now, is drinking a lot more water than we drank when we were their age. So I can imagine that that will continue into their adulthood. Even trends like it's trendy to exercise now and, you know, count your steps and that kind of stuff. So that will continue on into the older. So if we teach them the good eating habits from young, it will be easier for them when they become that older adults.
Yes.
Yeah.
That's very important. We have to change the culture a little bit, continue our traditions, but figure out how to make it healthier so that we can age beautifully. You know, we want to live long, and we want to live long, capable and able to be independent and carry out our daily functions for as long as possible. And I also want to highlight the issue of social isolation. I know this week with the nurses on radio would have covered that topic of older adults being abandoned, so to speak, you know, and we as community do need to play our part, because I never thought about that, but their nutrition is linked to, you know, them being social and we being in their presence. So it's important for us to play our role.
Penny, quickly. That's really one of the points I wanted to make, and that is providing a supportive environment. Because as you go older, you'll find that you're less capable of preparing your meals. And however, we live in an age where our older people, the elderly in our community, is not being cared for, even though they have their children and their family around, which says to me that there's going to be a serious problem in terms of them meeting their nutritional needs. So the question is, yes, we want our children to know how to eat and what to eat. I think we also need to inculcate in them that they have a responsibility to take care of us. The elderly, we took care of them when they couldn't take care of themselves. And now that we have become a child, in a sense, they need to take care of us. How we get that done in this age where everybody wants to go about their business, don't have any time. Just imagine that grandparents are saying to their grandchildren, I don't have any time with you. I have to go and live my life. So I'm saying, how do we now inculcate in these children, the younger population, that they have a responsibility to take care of us, when we know that the services that can be provided for the elderly are less. The cost is significant. And I can see us, if that is not somehow ingrained in those of us that are here right now, I can see myself becoming very poorly nutritionally fed. Not because I don't have the resources, but because sometimes I'm just neglected. Mm-hmm. And I think this is something that needs to be certainly taken on board.
And maybe that's something that we can look at, a piece of research in the future, you know, in terms of what our current attitudes and practices are to older adults and the care of older adults, you know. So thank you for that, Mr. Howe. So we will now have a video presentation by Rachel Jackson. So just like we had Lydia Robson this morning, Rachel was a NHS fellow here in Montserrat. She's a community practice educator with the Clauderdale and Huddersfield NHS Foundation Trust, that's in England. And she was here for 3 months, and her placement was intended to support local healthcare, workforce development, and community-based practice. And she brought a wealth of knowledge in nursing education, and I do know that she did some good work here, and we're going to hear about that today. Reducing diabetic amputations at Glendon Hospital, implementing a standardized diabetic foot risk stratification tool. So just as we did this morning, we'll listen to the presentation, and then we'll have our own discussion around what we hear.
Welcome everyone. My name is Rachel Jackson. I am a community practice educator for Calderdale and Huddersfield NHS Trust. Today I am presenting on my project. My aim was to reduce diabetic amputations at Glendon Hospital by implementing a standardised diabetic foot risk stratification tool. To understand the need for this, the burden within Montserrat, they have a high prevalence of diabetes and hypertension. I undertook a retrospective review of admissions to the ward between 2020 and 2025, and I identified 15 diabetes-related amputations. This equates to roughly 1 in every 293 residents undergoing an amputation over a 5-year period, emphasising the importance for this tool. So this project addresses the critical and disproportionately high rates of diabetes-related amputations on the island of Montserrat. Upon reviewing the local clinical landscape, I identified a need to resolve the lack of standardised screening and structured escalation protocols for diabetic foot ulcers, a gap that unfortunately left high-risk patients vulnerable to preventable complications. My mission was to successfully implement a universal diabetic foot risk stratification tool, or RST, across all clinical departments, including community and hospital. With this, I produced accompanying educational patient leaflets for early detection of foot problems, ensuring consistent escalation and significantly reducing avoidable amputations across the island. So the tool is more than just a checklist. It is a critical safety net for residents of the island. By moving from reactive care to proactive assessment, we can catch those silent diabetic foot complications before they become life-altering wounds. Evidence suggests approximately 85% of diabetes-related amputations are preventable through early identification. This tool provides a unified, evidence-based, objective framework. Whether a patient is seen by a community nurse or in the hospital, the escalation triggers are the same, and this ensures consistent and evidence-based care. We know patients often forget oral advice, and by using a visual traffic light system, we improve health literacy. It gives them a concrete way to understand their own risk level and, crucially, empowers them to recognise the red flags that require immediate attention. And crucially, this tool bridges the gap in specialist care. Montserrat currently lacks an on-site podiatrist, and this RST provides the non-specialist clinicians with the structured support needed to feel confident in making clinical decisions. Because they don't have a specialist podiatrist on the island, these leaflets have been produced, and they aren't just extra information. they're a critical safety net that bridges the gap between the clinical assessments and the patient's daily routine at home. We know that patients often forget up to 80% of the verbal advice given during a consultation, and that's immediately after they leave the room. So in an environment where they don't have a specialist podiatrist on site 24/7, they can't rely on verbal advice alone. So that is why I introduced these standardised patient leaflets. They serve as a critical home reference for the patients, and they are designed to align directly with the risk stratification tool. So for low risk patient, the leaflet acts as a guide for routine self-checks and healthy habits. By providing these, we're doing more than just handing out paper, we're empowering patients to take ownership of their own foot care. Studies have shown that literacy appropriate materials like these can improve treatment adherence by 16% and significantly reduce the incidence of new ulceration. This is the moderate risk leaflet and includes clear red flag section. This doesn't just list symptoms, it tells them exactly when to escalate and who to contact. So to achieve this, I anchored the project in established quality improvement and structured methodologies. My core methodology relies on the PDSA, Plan, Do, Study, Act cycle, and this iterative approach allowed me to systematically test, evaluate and refine the clinical workflow based on real-world feedback from frontline staff before moving to full-scale implementation. I utilised several quality improvement tools to guide my progress. I also use a stakeholder map and proactively engaging leaders early on, including the CMO, surgical team and community nurses to secure critical early buy-in. I used a driver diagram which allowed me to visualise the primary and secondary factors driving island amputation rates and ensuring I focus my limited project resources precisely where they would have the most impact. Before rolling anything out, I conducted a comprehensive survey to assess baseline clinical staff knowledge and confidence. This helped me to pinpoint specific training gaps, such as identifying Charcot neuropathy, so I could tailor my approach. I am incredibly proud to share the key outcomes and achievements of this initiative. First and foremost, on the 24th of April 2026, I successfully launched the evidence-based RST island-wide. Following my integrated training sessions, I saw a measurable shift in staff confidence. In pre-questionnaire, staff scored an average of 3.1 out of 5 for their knowledge of escalation, and this improved with an increase to 4.12 post-education. So staff confidence improved by 1.02. I successfully standardised escalation pathways across both the hospital and community settings, ensuring seamless, streamlined diabetic foot care no matter where a patient presents. Alongside clinical pathways, I focused heavily on patient education, creating and distributing tailored patient-facing leaflets that clearly distinguish between low versus moderate or high-risk categories to improve self-management. And finally, to guarantee the long-term sustainability of this project, I have completed a formal handover for ongoing oversight to local partners, Ward Nurse Hercules and Public Health Nurse Henry, who will sustain the clinical work moving forward and integrate it into ongoing training. How will this impact on my current work in the UK? So the insights I have gained in Montserrat are already clinically shaping my current clinical practice and quality improvement work here in the UK. This experience fast-tracked my resourcefulness and adaptability, delivering a quality improvement project entirely on my own, despite significant environmental constraints, such as infrastructure issues, limited desk space, and needing technical workarounds. These have built a unique resilience. It has also completely transformed how I approach quality improvement within resource-pressured environments in the NHS. I also gained invaluable experience in strategic quality improvement leadership at a system level. I learned firsthand how to translate healthcare theory into practical live protocol that successfully bridges the interface between acute hospital care and community medicine. And finally, this project reinforced the power of clinical leadership rooted in deep prevention. Prioritising community-based education has highlighted just how necessary it is to empower patients to own their health journey, a philosophy I will firmly integrate into my future practice in the UK. So just to conclude, I wanted to share 4 top tips for the future fellows embarking on similar global health or quality improvement placements. Firstly, I would say be flexible with timelines, avoid being overly rigid, local operational nuances, whether this is surgical days, school sports days, or community events. These will heavily impact schedule availability, so always build buffer time into your project plans. Secondly, identify champions early on. Building those strong, genuine relationships with local nursing leaders is absolutely crucial. They are the real drivers of institutional change and the ones who will sustain the clinical work long after the placement ends. Thirdly, plan for infrastructure realities. Anticipate environmental and technical hurdles like unreliable connectivity or lack of office space. Always have a plan B, such as offline templates and mobile hotspots. Have these ready to go before you even arrive on site. And finally, listen first. Start your placement with agendaless conversations, taking the time to truly understand the local clinical culture of the distinct barriers staff face is significantly more important than rushing into preconceived external ideas. That's my presentation. Thank you very much for your time, and I hope this has answered any or most of your questions. However, if you would like to ask me any further questions, please feel free to drop me an email. My email is rachel.jackson@cht.nhs.uk. Thank you.
I like the picture that was just there with the nurses. I thought that was quite lovely. Okay, so let's get the discussion going around this project. Any thoughts that anyone would like to share? One of the things that jumped out to me was the statistics that she quoted in terms of, from her calculations, 1 in 293 persons in our community will will have an amputation at some point in their life. To me, that's a lot. I feel like that's a lot. And I also noted that in discussing foot care, she also discussed health habits. It seems like our discussions are all coming right back down to our plates. On her screen, she said her recommendation is half a full plate of non-starchy vegetables. So it seems like that is one of the key messages that we need to be driving home. And I'm hoping that we can reach a space where we see that as a feasibility when we tell our clients that that is actually something they can achieve. Nurse Gray, I see you.
It's just to highlight that from her presentation previously, when she had it with us, it was noted that she didn't specify the amputations because there are times you have just digit amputation as opposed to the whole leg. So it's just to point that.
Yeah, so some of them would just be a toe or two versus a foot. So we have a comment that said a toe is plenty still.
Penny, having listened to the presentation and looking at something that I saw yesterday, I want to know how you can bring both together. Just yesterday, I saw someone, and they said to me, look at my toe. And it was discolored. And I said, since when it has been discolored? And she said, just today I noticed it. Yesterday it was not like that. I said, so what are you going to do about it? And she said, And I said, listen, do not try to manage it, go to the clinic. So I'm just saying that yes, you have a tool that looks good, it's working, but then how do patients recognize that they have a responsibility? Because when I asked the question, it was like, I don't really want to go to the clinic. You could see it in the person. And I'm saying, listen, you need to go now, because when you go, it might just be too late. So for me, the tool is wonderful, but then how do we now bring the patient and the tool together? I think that is something we need to think about.
Yeah, so we need to get the clients from just seeing that something is wrong and taking action. And maybe it goes back to our conversation earlier about a health psychologist. Although the health psychologist only works if clients go to them. So it almost seems as if it's a cycle and a little bit of a challenge, but I think it's one that as Ministry of Health staff, we can rise to the occasion and see how we can answer. And I'm hoping that the risk stratification tool that she spoke about is fully in use and it is bettering the landscape of care for our clients on Montserrat. Any further comments or questions around this presentation? Oh, I see one, and then we'll go to the next.
Okay, so Rachel is no longer here with us, but she mentioned that Nurse Henry and Nurse Hercules have been tasked to continue the education and use of the tools. So maybe going forward, we can have some community education sessions, including the Montserrat Diabetes Association, to help to push the message of using these tools within their group and also in the wider community, because we might have the tool, but it's not reaching persons. So we would have to try and get it out there more.
And I know in recent times we've done some work around foot care. Last year we did a massive screening campaign. We also had a surgeon, the specialty is evading me, a vascular surgeon for the first time on island in December last year to help us with this problem. I see somebody else approaching the microphone.
Morning again. I want to follow on with what Dr. Skerritt was asking, because maybe it's because I'm out of the system, but I have never seen this tool.
Well, this is brand new, fresh
So I was
tool.
just curious, is it a tool that is just for health providers to utilize, or is there any leeway, for instance, as she said, to have training with people like, which have I gone? The Montserrat Diabetes Association, which is a stakeholder team, who can also be part of it, because at the end of the day, the more hands on deck, the better. So, and if anybody have a copy of the tool, I would love to see it.
So it was a tool level. Nurse Henry, you want to address that? I know that it was a two-pronged approach, where there was a tool for staff to use, and there was also a tool for patients to use. So Nurse Henry, you want to take that comment, that
Yes,
question?
so the tool is catered for persons who attend the health center, but it can be tailored to provide teaching for like the Diabetes Association. So yes, we can partner with the Diabetes Association to do training, but as you said, the persons or individual have to come to us, and we have to teach them how to recognize that there's a problem that needs attending to. Unless they can be self-aware to know what's norm from what's normal, from what's abnormal, and seek help early, we will continue to have these issues. So yes, the tool is there. It can be tailored to do as a teaching tool that others can use. And yes, coming up next month, we'll be doing retraining of staff as well to continue to familiarize themselves, and as part of our annual screening for diabetic clients who attend our health center, foot screening is part of that.
Okay.
Thank you.
Thank you, nurse. One more comment?
Yeah, just to think about how we're going to reach patients. So I was thinking about radio, public service announcements on the radio. You know, if you see XYZ presenting in your feet, here's what you do, that kind of thing. The other thing as well is the Ministry of Health have a mobile van.
Yes.
So we can get using that to visit around different communities and areas. And also, you mentioned the health psychologist. I'm thinking perhaps home visits should be part of their duties.
Yes. And I guess this is a good opportunity for me to put a little plug for our mobile van. We'll be out in communities starting next Friday, the 7th of August. So we are embarking on an island-wide initiative to have persons get even more accessible healthcare. The van will be in several communities, all the communities across Montserrat, and we're encouraging persons to come on out and have those screenings done. Our next presenter to take us to our lunch break will be Dr. Tiffany Skerritt Fleming. She's a medical officer stationed at the Glendon Hospital Casualty Department. She also bears a burden of responsibility for infection prevention and control, and it's under that umbrella that she is here to present Playing with Fire, Why Antimicrobial Resistance Surveillance Matters in Montserrat.
Thank you, Penny. Good morning, everyone. I know that I'm the only thing standing between you and lunch, so I will try as much as possible to be efficient. I've chosen this title because antimicrobial resistance is something that is dangerous. I want to compare it to fire because we should not be playing with fire, and so we should not be playing with antimicrobial resistance. I'm presenting on behalf of my team, Kimona Daniel-Bourne and Rosie Collins, who has departed. She was our EP for a few months, and we're grateful for her time and her efforts with this project. All right, great. So a quick overview. I know we have a mixed crowd, mostly health professionals, but antimicrobial resistance is considered a growing public health concern. What is it? All this long word means is that antimicrobials, which are those drugs designed to kill germs, the bacteria, viruses, parasites, etc., those bugs have now adapted, they've now changed, and they no longer respond to these drugs. So to break it down for our listeners, prime example would be our antibiotics. Everybody knows what antibiotics are. They are drugs designed to kill bacteria. But we're now in an age where these very smart bacteria have adapted themselves to be resistant, which means when we treat you with antibiotics, some of them do not work, right? So we're concerned about this, not only on a local level, but on a global level. And especially in our setting of beautiful Montserrat, where we have limited resources and limited lab capacity, we want to ensure that we test these bugs and know exactly what they're sensitive or resistant to. Not only in Montserrat, but in other settings, we like to give antibiotics based on what we believe it is. And so when somebody presents with what seems to be an infection, we do a test of some type of sample, and we start you on antibiotics. And a few days later, you'll probably return, and we confirm whether the antibiotic we've put you on is the appropriate one. But before we confirm it, we do an empiric or just a generic medication that we believe would work. Right now, we don't have any local data that guides what we use, and so that is why we conducted this study. Now, when it comes to antimicrobial resistance, we have several partners. The Ministry of Health locally is the main agency or institution that's making this problem known, but we have several regional and international partners. These include the Caribbean Public Health Agency, of course, UK Health Security Agency, also known as UKHSA, and most recently, ICARS, which is the International Center for Antimicrobial Resistance Solutions. These partners provide funding in the form of sponsorships for workshops, in the form of necessary equipment for our lab, up-training for our lab staff, etc. And this is what allows us to do the work that we need to do. So what did we do? We looked at 1 year worth of data. We started in July, looked at the data from our lab from July last year to June of this year. So pretty up to date, pretty recent. And we're basically trying to figure out of all the samples we've taken, or cultures that we've taken to look for bugs, what does it show? Our objective was to look at it initially just comparing 6 months versus 6 months, but our data set is small. So really what I will present today is a full year of data, no comparison between sets. We've aimed to figure out, based on the particular bacteria or bug, what is it sensitive to and what is it resistant to. And we want to use this as our baseline for deciding which antibiotics we use, especially in casualty where we admit persons and start them on meds before they go to the wards. So At this time, I would like the members of the lab staff to stand, and I want everybody here to put your hands together in appreciation for the work that has been done. Please stand. And please sit. These 534 samples are just a subset. That is to say, microbiology represents one of several departments that these persons are in charge of. So over the last year, we have processed 534 samples, and the breakdown is clear. Clearly, we love urine. Clearly, we love to sample urine, and it's one of the more common reasons why people will present, because they believe that they have urine infections. We also do quite a few HVS. HVS stands for high vaginal swabs. These are performed to determine what may be causing a vaginal discharge that women present with. We also swab wounds. We also take blood cultures and other areas. So this is a nice summary for you. But urines really win in terms of the dominant sample type. This gives us a breakdown by those sample types of the results. So I want you to zoom in to color, because that will make it easiest. Blue represents no growth. And I want to especially speak to my fellow prescribers and colleagues. It's important that before we take off samples and before we ask persons to do samples, that we take a good history. If these persons, for example, present with symptoms that might be for a UTI, but they don't tick all the boxes, it's not helpful to do a urine culture, because as we see, about 40% of them show no growth, meaning there's actually no bacteria, meaning there's probably another potential cause for the symptom that they're presenting with. So that initial screening is important. The purple represents speciated, meaning our lab staff is able to isolate and determine exactly what bacteria, which species is causing the issue. And if we zoom in on the HVS, which is the high vaginal swabs, we see that majority of these samples are of two categories, either Candida, which is a common variety of yeast, or bacterial vaginosis, which is another very common vaginal infection. So that's just for you to have an idea as we go forward. We've also done a breakdown by type of organism. I know that the writing is kind of small, but the most important thing for you to note here is that E. coli is the most common bacteria that we isolate. Most of the E. coli is found in urines, but we're also seeing Staphylococcus, which is the next most common bacteria that we isolate. And quite a few of these are being found in our wound swabs, because we know staph occupies the skin, so it's not uncommon to find that. All right, so let's dive into, first of all, the vaginal swabs. Of the vaginal swabs that were sent to the lab, 173 total. We've isolated 60 samples in which bacterial vaginosis was the presumed diagnosis, and 29 samples in which yeast or candida was the presumed diagnosis. This is very helpful. So what we want to be able to say is, if we know that more than 60% of the time when you swab a female patient, it's one of these two organisms, the question can be asked prior to doing the swab. Knowing that this is what circulates in the population, should I presume and treat, which you can, because we know statistically what is common. And if there's failure to respond to treatment, so you've tried a treatment because you know what's common, if that treatment fails, then you can support that with a swab. So instead of swabbing being the default in the case of high vaginal swabs, because we know what is now predominant, we can opt to treat, and if treatment fails, then to do a swab to confirm diagnosis. You'll find as well that there are a few other organisms which are called coliforms. They're found in the gut. We know that the perineum is a very small space. There's vagina right next to anus. So it's likely that there's some cross-contamination or some of the bacteria that we typically find in the gut, in the vagina. That's not abnormal. What has to be correlated is with the physicians. If you're seeing something that is abnormal and you'd like to have it tested, you can and should go ahead and have it swabbed. So I want to focus on urines because that's the big boy, right? Currently, and over the last 3 years, through support with the UK HSA, we've been provided with an app. The app on our phone was previously called MicroGuide. It's now been rebranded to EOLUS. But basically, this app provides guidance to us as physicians that say, if you have a patient presenting with this infection, what your first line of treatment should be. If you have a person presenting with this infection and they're allergic to your first line, what you should use. So these are just 2 screenshots to show you, for example, for UTI, our first choice based on recommendation should be nitrofurantoin. That's a type of antibiotic. or we can do trimethoprim. And if that doesn't work, we have second-line agents. In its initial rollout, the plan was that each of the prescribers should be checking with the app so that as much as possible, our prescribing would be uniform. What we found is that there's variable use of the app, so we're not necessarily all prescribing based on guidelines. What we're hoping, though, is that with our own local data becoming available, then those guidelines can be more tailored to what is happening and what we're seeing on island. So we have a comparison of both. If we think the person has an infection of the urinary tract originating in the kidneys, ciprofloxacin is the preferred first agent, or augmentin, which is coamoxiclav, and then there are alternatives. So this is important for our next slide. I want you to look at the graph, and based on the susceptibility, I want you to tell me which antibiotic you would want prescribed for you if you had a urine infection. Slow. There we go. Went too far. Oh, somebody's helping me. Great. So again, 1 year worth of data. We're only looking at E. coli because that is the most common bacteria we're finding in urine. This is not a complete antibiogram, and I'm saying that now because although you saw 500 and something samples, in order to create a very reliable antibiogram, we need to have at least 30. So E. coli was the only organism that met the threshold for us to do this full examination. And we're looking at the susceptibility. That is, will this particular bug be killed or respond well to these antibiotics? And you're looking for those medications where you see ideally greater than 80%. We want to treat persons with medications where we know that at least 80% of the time these bugs are susceptible or will be killed by this antibiotic. And you can see our friend nitrofurantoin, I don't have a laser, but the nitro is at 100%, which means those 30 samples that were tested that had E. coli, all 30 of them were sensitive to nitrofurantoin. So that means for us prescribers, with some level of confidence, if a patient's presenting with a UTI, I should think, most likely, if they have a positive dipstick, they have positive symptoms, I'm sending off the culture. Even before I get that back in 48 to 72 hours, I can start them on nitro. And it's very likely that nitro will do the trick. That's if it's a lower UTI. Now, as you can see, we have variable numbers tested. So you can look at the line that says number tested. Not all samples were tested against all antibiotics, right? And of course, we know that there's variable supply into the lab, what's available, etc. But we also can come across and see, if we were to look at the top, those with the highest numbers tested, we also look at augmentin, which is coamoxiclav. That's another drug we use pretty often. And 62% of the time, patients who are given augmentin will respond. So it's not as high as we like. The gold standard is really 80% and above for susceptibility, but we realize that it is not fully there. So it's a consideration, but depending on what you're seeing, you'd prefer to use nitro if it's lower. Now, I know my AMR colleagues who are watching and those looking closely are also looking down to the right where we see ciprofloxacin. Cipro was one of the highly recommended. However, it's not as often tested for. So in order to determine if there's truly resistance, we would have to test more samples against Cipro. And we really like to use Cipro. So that has to be a priority for us in determining whether it should still be first line. Ceftriaxone as well has good susceptibility, but again, not as many samples were tested on the E. coli for it. So broadening our testing profile is part of what we aim to do. And I know the mini labs is coming along later this year, so we have things to look forward to when it comes to this. All right. So what are some limitations? As I said, the big number looks good, 500 and something, but when you want to compare them by organism or by sample type, we don't have as many numbers. So it was a small sample size, and we figured that in order to gain a bit more information, we'd probably have to prepare this report using at least 2 years of data, right? Because of that, we are at risk if we try to combine too many of the organisms, too many of the samples, of creating reports that are not as accurate or not as sensitive. So we're mindful of that. some of the recommendations coming out, as I might have indicated earlier, we want to see we see very high numbers of vaginal swabs, and majority of them have a pattern of either BV or Candida. And so really we can focus on symptomatic treatment, meaning that we don't have to swab everything. We know what's common, we treat it, and only if that treatment fails should physicians be thinking, yes, I really should be swabbing this. This allows the reduction on the laboratory burden. As you see, there are 3 people here. And that is our complement at the moment, ±1, when we are blessed with extra help. And so we want to be mindful of how many samples we're sending and if we're really sending the right samples and if the quality is good. Also note that the number of wound samples was quite low. And from our research, it seems that wound swabs are considered to be low quality. What they really want is for us to be collecting the pus. And pus is really what is preferred, or tissue samples, but pus is adequate, and that is really the focus. If you open a wound and you're able to get the pus that's there, and not so much the surface elements, that's a better source, a purer source of sample. All right, so what are some next steps? We're hoping to form a stewardship team, an interdisciplinary team. We know that the fight against AMR, the firefighters against AMR can't be of one kind. So we're looking to recruit members from all different parts of the healthcare team, from lab, from prescribers and clinicians, nursing, pharmacy, combined with the support from the UK to ensure that we continue to build this momentum and that we continue to advocate for resources, for staffing, for equipment related to reducing AMR. We've set a goal of doing this report biennially, that's once every 2 years, so that we have adequate data to report on and data that can be more useful to our prescribers. We're also hoping that by putting together this data annually, we'll be able to improve our empirical prescribing. As I said, we make a lot of assumptions. We see this is what typically works, so this is what we use first. Or our guidelines, which are not necessarily guided by our local patterns, are our default. We'd like to change that. Long term, we're hoping to extract this data from our new electronic lab system, and this will make it easier for us to extract that data and be able to make real-term or immediate decisions about what we're seeing. And we're hoping that because we're going to be reporting to the wider UK Overseas Territory Network, that we'll be able to build a working group, and that in turn we'll be able to fulfill certain goals. Kim and I would have attended a workshop in February in Gibraltar, and we have some outstanding things to do with that, as well as through our work with the ICAS team, Nurse Gray, Rona, Kim and myself have commitments related to antimicrobial resistance and what we're doing on Ireland. So these are new partnerships or ongoing partnerships that will continue. I want to just close by saying a huge thank you. I think Rosie should be watching us online, so a huge thank you to Rosie, to Kim as the head of our lab, and to all of our lab staff for doing the work that allows us to analyze this data and make more informed decisions as prescribers, to the UK HSA team who supported through workshops and other elements, to our ministry and all our nurses and prescribers who look out for our patients and say sometimes, Doc, this patient should have a test. Doc, did we culture this patient first? Those reminders are crucial, and ensuring that we maintain good patient standards and continue to fight this war against antimicrobial resistance. So thank you, and open for questions.
I hope my question makes sense. My dad recently passed away from a complicated UTI. And one of the things that we were told is that as soon as they go in, before you can even finish say the word UTI, they prescribe Cipro. And I was also doing my own research and finding that it's widely used across the Caribbean. Mm-hmm. But then seeing your presentation,
yes,
it's very disheartening to know that a medication that's so widely used across the Caribbean for this thing is so low in effectiveness. Mm-hmm. And is it that it's is it that it's the E. coli, or is it that it's just not effective?
Okay. So first of all, condolences to you, Charlene, and to your family. The issue of resistance is a huge challenge, right? Not only because the bugs are smarter, you referenced E. coli, but basically what happens is that they're exposed, especially if these bacteria are exposed to antibiotics over time. So if you've had an infection before and you've had to take antibiotics and these courses were not for long enough to kill that bacteria, then the bug will adapt. Because those that survive, if all of them don't die, those that are left will adapt and produce special characteristics so that the next time they encounter that same drug, it will not work.
So re-prescribing somebody the same drug.
So it's several things. So AMR is driven by different behaviors. It's one, us overusing antibiotics. So using antibiotics in scenarios where they're not needed, where they're not necessary, and therefore exposing bacteria to antibiotics that they can become resistant to. It's also in patient behavior in terms of people not completing courses of antibiotics, not then, but at any point in their lifeline. And we know it can be difficult because often we treat for so long, and that's one of the things that we're now adapting, that if you don't need to treat for a week, you treat only for the amount of time so that you kill what's there and those that remain of other types don't become resistant. We know that it's also connected to our food because of how much antibiotics is being used now in agriculture. And so what we consume is also important. So it's a big fire. And that's one of the reasons why it's such a big fight. As you mentioned, in this particular data set, there is some notable resistance to Cipro, but there are very small numbers, as you can see. It wasn't the full number that were tested, but what we're aiming to do is that when we test these samples, that we have that full profile, so that we're able to adapt. You know, most times our cultures take between 24 to 48 hours for initial reports. And what we want is better feedback, prescribers ordering and checking back with the lab to say, what's the initial, what are you seeing, what bug is there, what is the bug responding to, so that we can adapt much quicker, because we know that infection and sepsis is a major cause of morbidity and mortality.
Okay. One last thing. So the ones that had like 100%.
Correct.
Why are we not prescribing those more? Is it a case that they cost more? Or?
No, we have them available.
Yeah.
And part of it, as my pharmacist is nodding to say, is that cost is a factor, availability is a factor. But what we're hoping to do is that by producing local data, we can adapt. It's one thing to use the app and say, okay, this is what the UK would recommend based on what they're seeing, but our patterns are slightly different. Our exposure levels are also different. And part of our job as prescribers will be building that relationship with the lab and ensuring that our prescribing is much tighter. Yeah?
Thank you.
You're welcome. Two questions.
I was just saying, as Charlene was asking, why we don't use the drugs that say 100%.
Yes.
But we have to remember that, as you say, they will test.
Yes.
So you'll get whether it's sensitive or resistant. So
Correct.
even though it's 100%, it might
You
not
wait for
work
that result, yeah.
on that patient.
So Sister is making a great point. So even though we're going to have medications that we start post-test, we'll take the sample, we start the antibiotics immediately because the patient is having symptoms or feeling sick. Once we get that report back from the sample taken from that patient, we will change based on that report to the medication that is more suitable. Dr. Amara.
Hi, Dr. Skerritt. It's just a curiosity question because as everyone knows, I'm British from the UK.
Yes.
And in the United Kingdom, with bacterial vaginosis, BV,
yes,
the standard care over there is some antibiotic called metronidazole, something like that.
It's a combination, yeah.
I was just curious why that was not in your lineup there.
Well, this was only for urine. The samples were only for urine. We didn't look at the vaginal swabs in this in that diagram. Yeah.
Is that available here? The one.
What's that? The metronidazole? Yeah, we have metronidazole.
Okay.
Yeah. Okay, I can pass the message. When we do the when the lab processes the high vaginal swab, once we identify the chosen organism, we don't do sensitivities on them because the treatment is established, it's known. There's a standard of care for those, so there's no need to test for sensitivities, yeah. 2 more questions. Guys, I just want to say, for those listening virtually and those here, I am not holding you up from lunch, okay? Let's go.
I also just wanted to point out that for bacterial vaginosis, the identification is done via a slide. So there's nothing on the plate that grew to let us know there's BV. It is something that we see on a slide, a smear that we've made and stained to be able to tell the doctor, okay, well, yes, this is what we're seeing, they have BV.
Excellent, thank you.
Very good presentation, Dr. Skerritt Fleming.
Thank you.
It would be good as a follow-up if we compare our local data to regional data. So for instance, in that very painful situation, you know, what are they seeing, your colleagues in Trinidad, what are they seeing there versus what we're seeing here? Because, you know, we can't generalize our data to, you know, what's happening over there. And the CAFA lab is based in Trinidad.
Yes.
So it would be good to see what they're seeing and then compare to see, you know, are we having the same problems in Montserrat versus around the region, or are we having a totally different demographic of organisms and so forth? Yeah.
Thank you. Well, CARFA would have released their annual report on AMR, I think, for 2025, so that's something we can share. And it breaks down by sample type what they're seeing in terms of patterns. Because they are the regional public health agency, they're able to kind of pool whatever data is submitted. So this work is important locally because now we can be part of that conversation. The work that was done by Rosie is crucial, and I want to go back 2 steps in that we collect a lot of data, and most of you know that, whether it's working in the clinic, working in the lab, working in the pharmacy, we collect a lot of data, but we don't have the time, the staff, or the necessary resource to analyze, process, and generate these reports in a timely fashion. So Research Day is great, we do it annually, but this is data that really needs to be pooled more regularly with that connection between EPI and us being more consistent, and that's a gap that currently exists. But thank you.
Okay, so not to hold you back from lunch, I will announce the break immediately. We'll break for 1 hour. There are lunches available at the back. We have fish and chicken. I do not know what else is on the inside, but I am assured that it is nutritious, and we will not just be fueled nutritionally, we will also enjoy this meal. Yes, so it's going to be good for us today. And enjoy your lunch, and I will see you back in an hour. Research Day 2026. Did everybody have a good lunch? Okay, was it healthy? Nutritious? Was it also tasty? Afternoon. To prepare us to get into those presentations, can we just stand and take a little stretch so that we don't fall into the lull, the after lunch lull? Let's reach up and wiggle our fingers, stretch out, don't hit, the person in front of you. Let's do the front. Let's rotate our ankles, get our blood flowing. Should I ask you all to do squats too? Okay, I'm told squats is extra, but I see Dr. Scarrett suggesting we do a little march on the spot, just to wake our bodies up and prepare us to listen again. Y'all look lovely, so thank you very much. Everyone, you can have your seats now. Our first presenter for the afternoon session is Miss Grethlyn West. Miss West, she is the Senior Health Information Officer. She's stationed at the Glendon Hospital. She is absolutely no stranger to this podium. She is the only person who has given a presentation every single year since the inception of Research Day. And I think we should give her a round of applause for that. So, Ms. West, we eagerly await your offerings this year, and she will be presenting Serving Montserrat 3 years of the Visiting Urology Clinic. And to help us with our discussion, we have Dr. Adrian Rudd online. He is the consultant, the urologist consultant who comes. So after Grethlyn's presentation, if you have any questions you want to ask, he is here to assist.
Good afternoon to our viewing and listening audiences. This presentation will highlight how a visiting urology clinic served Montserrat over the span of 3 years. Let's begin with a brief overview. Urology focuses on the diagnosis and management of urological conditions in both men and women. It includes non-communicable diseases such as urinary tract infection, kidney and bladder stones, and prostate and bladder cancers. Other non-communicable diseases such as hypertension and diabetes are often linked with urological conditions. The Visiting Urology Clinic helps people in Montserrat stay healthier by identifying NCD-related conditions early and managing them well, which reduces healthcare costs in the long term and promotes quality health outcomes for our citizens. This timeline figure shows the monthly and yearly patterns of the clinics. Over 3 years, Dr. Adrian Rudd from Antigua has held 8 urology clinics in Montserrat. But until now, there has been no meaningful data analysis of patients' records, specifically frequency of clinic attendance, service usage, and patient experience or health outcome. Our team conducted this study to address this knowledge gap. So we're describing the clinic's patients and evaluating their clinical outcomes over its first 3 years, that is from March 2023 to February 2026. Using a retrospective census approach, we conducted descriptive analysis of the study population to fulfill the following objectives. 1, describe the age and sex distribution of patients referred to the urology clinic and frequency of clinic attendance. 2, describe the subset of patients referred for ultrasound, biopsy, and surgery. 3, evaluate outcomes among clinics attendees with respect to referral for overseas treatment and mortality or death. Results. Clinic attendance. This figure illustrates how the visits were split between first-time consultations and follow-up appointments. Most patients came only once. A few required additional care, with some attending as many as 5 times. The pattern suggests that follow-up visits increase noticeably in later clinics, 6 to 8. The increase in new visits and rise in follow-ups implies that there is a demand for the service and that patients were complying and are happy to return for ongoing care rather than the one-time consultations. The clinic saw 206 patients, most of whom were men, 89%. Nearly half were older adults, with 70% aged between 60 and 79 years. 23 were females and 183 males. In addition to consultation, patients access additional care or services. Of the 107 procedures performed, over half use urology, 54%, followed by biopsy, 24%, and cystoscopy, 16%, and surgery, 6%. Radiology. A total of 58 radiology scans were performed. Most were ultrasounds, 79%. Prostate imaging was the most common indication, followed by accounting for 54% of scans, followed by urinary tract imaging at 22%. Ultrasound is a useful tool in urology to diagnose, monitor, and treat conditions such as kidney stones, prostate abnormalities, and bladder dysfunctions. CT scans made up 17% of imaging. Bear in mind that CT scan service only started in Montserrat in September 2024. While CT scan is a gold standard used by urologists to determine size, number, and location of kidney stones, some doctors order an ultrasound first. Biopsy. Truss or transrectal, Truss or transrectal ultrasound-guided biopsy is used to examine the prostate gland for cancer or other abnormalities. A PSA above 4 or an abnormal digital rectal exam requires immediate biopsy. Biopsy results were mostly positive, with 17 positive and 9 negative cases, approximately 65% positivity, suggesting that this procedure was well targeted towards patients most likely to have malignancy or cancer. Patients diagnosed with prostate cancer may undergo a CT scan to help determine whether the cancer has spread beyond the prostate gland and to assist in staging the disease. Flexible cystoscopy is commonly recommended for patients who are referred for evaluation of hematuria, that is blood in the urine, and recurrent urinary tract infections. This is a procedure where the doctor looks inside the bladder using a thin tube with a camera to check for problems such as stones, inflammation, or tumors, benign or malignant. 17 cystoscopies were performed. Only 3 patients were found to have bladder stones, and none was diagnosed with bladder cancer. Six surgical procedures were performed. Half of these were cystolithoplaxies. A cystolithoplaxy is a procedure used to break up and remove bladder stones. TURP, or transurethral resection of the prostate, is a procedure used to treat a non-cancerous enlargement of the prostate gland. It removes excess prostate tissue that would allow for better flow of urine. Some refer to it as scraping of the prostate. 2 of this procedure were performed. There were some patients who had more than 1 procedure. Patient outcomes. During the period under review, 5 patients were referred overseas for treatment, all to the United Kingdom, and all for prostate cancer. The remaining patients opted to receive conservative management locally. Among clinic attendees, 4 deaths were recorded. Prostate cancer was the underlying cause of death for 2 of them. As a means of comparison, deaths from urologically related conditions among non-clinic attendees were high, 14. 9 died from prostate cancer, while 5, even though they had prostate cancer at the time of death, died from a non-urological condition. Summary of findings. This study found that visiting urology services are provided 2 to 3 times a year. Older males predominantly are managed. Number of consultations and follow-ups are increasing. Biopsies and cystoscopies are the most frequent diagnostics performed, and in all cases, the patients were informed of their results. More research is needed to ascertain if early intervention for late-stage illness will reduce long-term costs. Bladder stone surgery and endoscopic TURPs are offered on island. Diagnostic urology has helped early diagnosis that allowed 5 patients to receive advanced care in the United Kingdom. And there is an ongoing service gap. The evidence strongly suggests the need for ongoing urology service. Recommendations. The visiting urology clinic plays a valuable role in providing specialist diagnostic service on island and facilitating access to advanced treatment overseas. Continue to support growth of the urology service on island, especially in light of our aging male population. Expand abilities to offer more services locally. Currently, we are performing cystolithoplaxies, that is the removal of bladder stones. Can we add the service to remove kidney stones for anyone who requires it? Use the findings from this study, such as clinic attendance and demographic data, to forecast future demand and determine whether clinic frequency can increase from twice a year. And assess the impact an increase will have on services and supplies to include laboratory, radiology, and pharmacy, as well as human resource. Develop targeted awareness campaigns to encourage men aged 50 years and older, or younger men with a family history or other risk factors, to attend assessment and screening. primary care providers can work with local media and community organizations, such as the Montserrat Football Association, to improve engagement among men who rarely access healthcare. For example, have players wear prostate cancer badges or armbands. Our findings suggest that the greatest burden of prostate cancer deaths is occurring before patients engage with the visiting urology service, rather than among those who attend it. To help address this gap, how about having an annual prostate cancer awareness day, or a prostate cancer poster placed at strategic locations, educating the public on prostate cancer symptoms, risk factors, and the benefits and limitations of early detection? Would you like to see a sample? Coming soon. Audit patients that are diagnosed with prostate cancer to determine the stage at diagnosis, PSA levels, time from referral to diagnosis, and referral pathway. Compare findings over time to assess whether the clinic is achieving early detection and reducing presentations with advanced disease. Ta-da! Our team's message to men is simple but important. Prostate cancer is common and often develops without noticeable symptoms. The good news is that when detected early, it is highly treatable. Taking the time to get screened is a proactive step that can protect your health, save your life, and help you continue to be there for your family, friends, and community. To the supporting staff, thank you. Thanks also to all our men out there who are taking ownership of their health. May you be an inspiration for others to follow. Thank you.
Any questions for Ms. West or Dr. Rudd? I am assuming he can hear us and he is online with us.
Loud and clear.
Yes.
Present.
So do we have any questions for Dr. Rudd or Ms. West this afternoon? I do want to say I think this was a very good presentation. It was excellent. I really like the suggestions, you know, from a health education perspective. And I am curious about the 14 males not enrolled in the clinic at all, but dying from prostate cancer within the same time period. So I'm curious to know, I don't know if Dr. Rudd would have interacted with them when because they had to have eventually come into our health system. Is it that he interacted with them at a point when it was then too far gone for anything to be done?
They didn't attend at all.
I don't think I ever interacted with them, so they never attended at all and would have probably passed away when I was not on island.
Okay, so we have two questions.
I was just saying that some of these patients, they see their doctor privately, and Dr. Tony Twaits, he comes from Antigua sometimes, so he too has his clients. So I'm just thinking possibly those were some of the patients that died. But of course, they came into our system whereby maybe and probably some of the private doctors see these patients, but never refer them to Dr. Rudd.
Okay.
And very good presentation, Sister Gwethlin.
Great presentation. I'm asking for a friend. How do you conduct the ultrasound to check the prostate?
Oh, maybe Dr. Rudd can answer that.
Okay, so the ultrasound is usually a part of the biopsy. But even before it gets to me, sometimes the radiologist, Antoinette Silcott, what they will do is put the ultrasound probe on the tummy and shoot the rays through the bladder to the prostate. So it's very painless, it is non-invasive, and you can get a rough estimate of the size of the prostate. That's all you get. From my standpoint, when I'm doing the biopsy, the probe goes through the rectum into the bottom and is closer to the prostate, and it gives us slightly better views. The issue is the prostate ultrasound alone is not very accurate at diagnosing prostate cancer. What we go by is the blood test, the PSA, or what it feels like with the finger, the digital rectal examination.
Thank you.
Can I ask another question? So we have a very small population, and I'm not a statistician, epidemiologist of any kind, but it feels like we have a problem, a real serious problem with prostate deaths on island, I say, and, diagnosis. From your professional perspective, should we be advertising for men to be screened earlier than the standard 50, I think it's 45 to 50, what should we be promoting here for our men as the Ministry of Health?
So here in Montserrat, it's from age, black males are at higher risk than men from Caucasian descent or white males. So as long as you're black or have a family history, it's age 40. So everyone should have their PSA done once a year. Now, you have a very interesting problem because without actually doing the biopsy, you do not have histological confirmation of prostate cancer. And it's a problem we're all suffering for around the region. Lots of men will come in with PSAs of 70, 100, 300. The PSA is the blood test that we use to check for prostate cancer and should be less than 4. So you want guys coming in when it is 1, 2, 3. But you'll have guys walking into their general doctors, to their general surgeons with a PSA of 40, 50, 60. And sometimes they will automatically be treated with the hormonal injection, never having a biopsy. So they're actually never technically counted in your statistics to know how much cancer is in your country. So only now we're actually biopsying them, you will start seeing the numbers stacking up and you'll have a true picture then. And it will be quite frightening, especially how your population is based on a lot of older patients, particularly men.
I see another question.
Not a question, but just a comment, just based on an experience that is close enough to me, personal experience, that sometimes men tend to get confused with regular everyday symptoms. So they might have a back pain that they might probably attribute to working too hard, or they do have an increased PSA, but the doctor might think, okay, maybe it's an infection. And then, a lot of time pass if you don't have that close monitoring of your situation. So men just need to, you can't doctor yourself. And even if you do go to the doctor, you still have to get more than one opinion because things can look like something when it's not. So you might think you have an infection when it's not an infection, you're treated with antibiotics, when your prostate is actually increased, not for inflammation or infection, but because you are going into the realm of prostate cancer. So a lot of different things to consider in terms of that.
Yeah. And I know that Dr. Rudd is working on a study. We were hopeful to have it presented here today, but it's not quite ready yet. So hopefully next year, maybe even before, we'll have some more insight into what prostate cancer really looks like here on Montserrat. Dr. Scarrett?
Yes, Ms. Gretlin, very good presentation, and thank you to Dr. Rudd for providing the services to our population. I just wanted to highlight that he mentioned it in terms of the presumed cancer diagnosis. So a lot of the time, the death certificate might say prostate cancer, but I would ask, Ms. Gretlin knows, I would say, was this confirmed or, is it presumed? And for some clients, I guess with some physicians, they would look at the client's age, their morbidity, look to see their prognosis and so forth, and then they might say, okay, maybe they might not opt to refer this patient to the urologist. But in my practice, once I'm seeing elevated PSAs sustained, I'm definitely referring them to Dr. Rudd to get their investigations done. So it's just for us to brush up on our screening and referral policies so that we can better capture more men and do early diagnosis and management.
Thank you. Yes, thank you, Dr. Rudd. And can we give Ms. West another round of applause? Our next presenter, this will be our last video presentation of the day. We have Dr. Hayam Al-Jabra. And if she's listening, please forgive me if I got your name very incorrectly. So she is a research fellow in epidemiology at Keele University. You would have heard about Keele University throughout the day. They've helped us with quite a few pieces of study. She is a pharmacist by professional background with a PhD in pharmacy practice. In relation to today's research day, she collaborated with the then epidemiologist Bill Berners-Lee, this was last year, to conduct a piece of research in mental health, and it's entitled Exploring Mental Health Experiences and Support Here in Montserrat. And I do know that they did sample the Ministry of Health staff, so some of us in here would have been in that focus group discussion. So here's our opportunity to hear from Dr. Al-Jabra on the results of that study.
Hello, thank you for having me today. My name is Hayam. I'm a research fellow at the School of Medicine at Keele University and also a research associate at the Department of Research and Innovation at Midlands Partnership University NHS Foundation Trust. In this presentation, I'm going to talk about a project that we conducted last summer in Montserrat that was focused on exploring mental health services and experiences by people in the island. So throughout this presentation, I'm going to talk about a little bit about background to this project, its aims and objectives, the methods that we use, the results, and we will have at the end some implications that hopefully will help to enhance mental health services on the island. Mental health conditions are increasing all over the world, including the Caribbean and Montserrat as part of the Caribbean. There are several reasons behind that. It could include an aging population, loss of traditional support systems, substance misuse, chronic health conditions, unemployment, and could also sometimes be imposed by the acts of nature, such as volcanic eruptions. In Montserrat, the Soufriere Hills volcano, which was reported to be dormant for about 400 years, became active again in 1995 with a series of volcanic eruptions, leading to severely disrupting services provided to people, to a big part of the community in Montserrat, and causing many people to be displaced from one area of the island to the other area of the island, where living conditions were generally described as being poor, and also causing severe disruptions to health services. This caused many people to be displaced even to outside the island, and resulted in influencing mental health and well-being of many people and increasing mental health needs. However, in the Caribbean, including Montserrat, research in mental health is still limited, with no research done looking specifically at investigating mental health or mental health services or the long-term impacts of the SHV eruption. So this study aimed to explore the understanding and impact of mental health problems in Montserrat. And the study objectives were to investigate the awareness of mental health and the experiences of mental health problems as reflected by members of the public, service users, and healthcare professionals, to explore the long-term effects of the SHV eruption on the population's mental health, particularly on its 30th anniversary, and to identify barriers and facilitators to mental health support. So with regards to the methods, the design of the study was purely qualitative. So we used semi-structured interviews and focus groups, and we recruited two groups of participants. The first group was adult members of the community and mental health service users, and the second group was healthcare professionals who are involved in providing mental health services in Montserrat. With regards to recruiting participants, so patient and public members, they were recruited using poster advertisements that were placed in healthcare facilities and were also advertised using local social media, like an island-wide community Facebook group. Whereas for healthcare professionals, they were recruited by emails distributed by the Ministry of Health to its current employees. So both groups, those who were interested, were provided with written information booklets, and if they continued to be interested in taking part, they were consented. So the interviews and the focus group, they were guided by a topic guide that was developed in collaboration between academics and clinicians in Montserrat and Kiel University. The topic guide covered different areas, including general understanding of mental health, experiences of using mental health services, mental health attached to stigma, the mental health support provided to patients and to healthcare professionals, and the impact of the SHV eruption, particularly on its 30th anniversary. These interviews and the focus group, they were conducted face-to-face by a researcher based in Montserrat, and they were audio recorded and transcribed verbatim for data analysis. The transcripts of the interviews in the focus group were then analyzed using a thematic analysis approach, where common codes were identified and grouped together to identify main emerging themes. So with regards to the results, for the first group of participants, patients and public members, we recruited a total of 11 participants, 8 females and 3 male participants, and they were all individually interviewed. Whereas for healthcare professionals, we recruited a total of 8 professionals, 5 females and 3 males, and 3 of them were individually interviewed, whereas the rest were included in a focus group. So starting with the analysis from the patients and public data, 4 main themes were identified. So these themes, they focused on the views in mental health support, the impact of the SHV volcanic eruption, barriers to mental health support in Montserrat, and the strategies to enhance mental health support. So in the first theme, participants shared their general views on mental health and how it is viewed in the island, reflecting a high level of stigmatization with people with mental health conditions. They're usually being referred to as crazy or mad. Participants also talked about a wide range of existing support, including the support from family, friends, from church, and for some people, as a last resort, the support from healthcare professionals. The support, for example, provided by the church included, for example, praying and listening to people, and participants reflected a strong emphasis on the role of faith in supporting mental health and well-being. In this second theme, participants talked about the impact of the SHV eruption and how it influenced the lives of many people, with displacements and being forced to live in shelters and in poor conditions. People didn't know how long that would last and what's going to happen to the island. Despite the negative reflections of the impact of the SHV eruption, some participants did describe some positive impacts caused by the eruption, in which the displacement made them be away from a stressful situation that they were exposed to before the eruption. In this this third theme, several barriers were described by participants with regards to accessing and or seeking mental health support. These were mostly attached to stigma and gaps in understanding about mental health, its associated symptoms, and the sort of support provided on the island. Linked to this was as well the fear of breaching confidentiality and privacy. So people, they didn't want anyone to know that they were having a central mental health condition and that they were seeking support for it, so that not to be negatively labeled by the community of being crazy. Another barrier was related to the role of faith, particularly when some people, they were highly dependent on the support from the church to heal or to treat their condition, as participants viewed this not to be sufficient, particularly for chronic or severe conditions where more professional healthcare support would be needed. So in this final theme, several strategies were suggested by participants to help overcome barriers and enhance mental health support. These were highly focused on educating the community about mental health and about integrating patients within the community through community-based programs, so that to help normalize the condition and also to increase acceptance of people with mental health conditions in the community. Another strategy was to provide training to enhance mental health support, such as training provided to the church community, so that they know when they need to refer patients to more professional support. With regards to the analysis of healthcare professionals' data, so three main themes were identified. In the first theme, it focused on sources of mental health support that is provided in Montserrat. A range of different resources were shared by healthcare professionals, similar to the ones mentioned by patients and public members, the support from family, friends, from the church, as well as from healthcare professionals. And here participants talked about using like some measures to protect patients' privacy and confidentiality, like the clinic where patients go to in order to be provided with mental health support also provides support to other healthcare conditions. So when someone goes to the clinic, no one will know why you're there and who professional you're going to see. In this theme, participants talked about barriers to mental health support. A range of different barriers were shared, including similar ones that were mentioned by participants in the first group, like stigma and gaps in understanding about mental health and its symptoms. Additional barriers included lack of understanding, knowledge and skills by some healthcare professional staff, which made them feel uncomfortable in managing people with mental health. Another barrier was related to limited financial resources that were dedicated to mental health, and lack of sufficient mental health staff on the island. On this final theme, participants talked about strategies to enhance mental health support on the island. Some of these strategies were focused on reducing stigma by increasing awareness and understanding, not only for the community, but also for healthcare professionals, and increasing knowledge about what mental health means and what's associated symptoms and what needs to be done if someone is trying to seek support, who they need to call. Another strategy was focused on updating mental health related policy documents. The Mental Treatment Act was particularly mentioned as an outdated document, and that there are lots of phrases used in this document that is not considered to be acceptable in today's healthcare systems. Other strategies included increasing outreach activities that targeted different components of the community. Providing trainings as well was mentioned to healthcare staff so that they would increase their knowledge and skills on how to manage and work with mental health patients. And also another strategy was to provide support for healthcare professionals themselves. From one side, to ensure that their well-being and mental health is taken care of, and on another side as well to provide them with financial support so that they will be able to participate in different activities to help their continuous professional development. So, putting the findings from both groups, implications for practice to enhance mental health support in Montserrat should include the following elements. So, from the patient and public side, implications should include enhancing public awareness by using different sorts of outreach activities, normalizing mental health illness in the community, similar to how other physical disorders like diabetes and hypertension are being looked at and being normalized in the community. Integrate patients in the community through various community-based programs and activities, providing training to church professionals to increase their awareness and knowledge of mental health and when they need to refer patients to more professional support, and always maintaining patient privacy and confidentiality, and offering flexibility in service delivery. So, for example, if a patient needs a remote appointment, to provide this where possible. The implications suggested by the healthcare professionals included softening mental health terminology. So, for example, using terms like welfare or well-being would be less off-putting than directly using mental health. Another strategy focused on updating mental health policy documents so that they are using language that is non-stigmatizing, and to make these policy documents in line with current recommendations for mental health support. Providing trainings to different components of the community, to healthcare professionals, to service providers, including police and church professionals, to improve financial, physical, and human resources to improve mental health, so and to be dedicated for mental health and increase the number of mental health staff. Adopt the clinic setting to support mental health. So, for example, if the clinic is for young people, then a play therapy could be used. So, adapting the clinic to suit patients coming to the clinic. And finally, regular inspection by a third party so that to ensure that mental health support is being provided according to the agreed standards. And before I finish, I would like to thank the research team for designing and carrying out this project. And thank you all for listening.
All right, so just as we did earlier this morning, we will have our own in-house discussion on what was presented here. So anybody wants to get the ball rolling, any thoughts or comments that you would like to share at this time? What I would like to share is that she mentioned a gap in the long-term consequences of the volcanic eruption, and I remember being struck by that when St. Vincent's, is that also Soufrière, when their volcano erupted. So it's not so long ago. I was right here on island, but I was able to view that very much passively and sympathize. But when I looked, having conversations with persons who went through the crisis here, I saw people cry. I saw people have really sincere, visceral reactions to St. Vincent's volcano, and that highlighted to me that there was trauma there that is simmering under the surface, and I don't know if it's something that we can address here. We have mental health staff in the room with us. Maybe that's something that we might want to explore. I know it might be a little bit of opening new wounds, but it might be useful to help us with future natural disasters. So that's a point that I think was very important to me. So if no one has any comments on that, it is my pleasure to introduce the last presenter of the afternoon. You heard from her this morning. At that point in time, she was wearing the hat of community mental health nurse. Now she is going to come as a former Chevening scholar. She attended the university, Lancaster University, where she did a master's degree in psychology, and she would have conducted some work on ADHD and a strengths and difficulty questionnaire that I think spanned a number of Caribbean islands. So please give her your attention right now. Thank you.
Thank you, Penny. Good afternoon once again, everyone. So this presentation this afternoon looks to share what was found during our testing of parent questionnaire on the SDQ, which is the Strengths and Difficulty Questionnaire, and to see whether it can identify ADHD in Caribbean children. And ADHD basically stands for Attention Deficit Hyperactivity Disorder, and it affects how children pay attention, manage their behavior, and regulate their emotions. And identifying it early can make a real difference to the child's life at home, at school, and during play. Is it me that this doesn't want to work for? Okay. So we will start with the big question, and that is why children in the Caribbean often go underdiagnosed with ADHD. And then we'll look at the study and what it involved, what we found, and what it means for how we screen children during our practice. So ADHD affects roughly 1 in 14 children globally, and that is a significant number. But in the Caribbean, fewer than 1 in 10 children are even formally screened, and there is no questionnaires that are validated to specifically relate to the Caribbean population. As a result, we found that there are 3 key barriers, and the first one is the tools we use are designed and validated in other countries such as the UK and the US. A questionnaire developed in America versus Manchester in the UK may ask about behavior or other things related to a child, and it may make sense to that population, but we are unable to apply it to the Caribbean because our culture is different, the way we interact is different, and there are so many other factors that may affect the response to these questions. Secondly, stigma is real, and many parents worry about what mental health label may mean for their child. And as a result, this stops families from coming forward and seeking help. And the third barrier is that we do not have enough specialist services when it comes to catering to the needs of our children and young people. And we need tools that a family nurse or maybe a guidance counselor or even a nurse in practice can quickly use to decide whether a child needs support, further support, or specialist care. And this gap, this study basically tries to identify how we can address the gap in that. So 50 parents across 5 Caribbean islands, including Montserrat, St. Kitts, Nevis, Barbados, St. Lucia, and Antigua, agreed to participate. They completed a SDQ online questionnaire about their child, and this questionnaire is a 25-question survey that takes about roughly 5 to 10 minutes to complete. About half of the children, there was a 50-50 split, were girls, and the other half were boys, and they range from the ages 6 years to 16 years. 14 parents reported that their child had been formally diagnosed. Of course, we were unable to verify this by checking records because it was done remotely. And 4 reported that they were unsure whether the child were diagnosed with ADHD. Now, the diagnosis was based on what the parents told us, and all analysis used carefully corrected the item scoring of the SDQ so that we have this scoring done correctly on a 0 to 2 scale throughout. So our key findings, this chart basically shows the average scores across all 5 subscales of the SDQ. And for each area, it is scored out of 10. The highest scores in the problem areas, such as conduct, hyperactivity, and peer problems, are scored 5 out of 10. For pro-social behavior, which basically looks at kindness, sharing, etc., scored 8 out of 10. And this tells us that even children who are struggling still show some important strengths in other areas. The total difficulties scored average of 13.5 out of a possible 40, and this is below the level where we're typically concerned about clinically. So a score of 17 and above is where there is concern, where it means that we need to look further to see what's happening. But when we look at each child individually, nearly 3 in 10 did score in a higher concern range, which is above 18. So this shows that while the average looks manageable to us, there is still a significant group of children who needs our support and needs attention. In terms of group differences, this is the most important findings that came out of the study. When we compared children with and without ADHD diagnosis, we found a clear difference in the SDQ scores. Now, children who had been diagnosed with ADHD scored an average of nearly 20 out of 40. Children without a diagnosis scored about 10.5 out of 40. Now, that is a gap of about 9 points, and statistically, this is a very large, meaningful difference, and it's not due to chance. In simple terms, the SDQ was able to pick up on the difficulties that a child with ADHD experience, and that is a positive finding. Age made some difference. Older children tend to score a little higher than the younger ones, but we cannot fully be certain of this with a sample of just 50 participants. Gender made very little difference. As we can see, it's just about 14 for boys. This analysis looked at which factors most strongly predict a child's total difficulty score, and 2 main factors stood out. One is having a diagnosis of ADHD, about 11.5 points to the score on average, by far the biggest factor. And the second one, age. Each additional year of age added about 0.9 points. So basically it's saying the older the child, it's expected that that child will score higher on the ADHD, whether or not they have the same level of difficulty to that of a younger child. And this is worth keeping in mind when we're doing screening for ADHD. Gender and family income made little to no difference, and together these factors explained about 56% of the variation in scores, which is quite strong for the study of this size, and the analysis used about 33 families who had complete information for all factors. Here we're looking at the receiver operating characteristic curve for both SDQ scores, and it plots the sensitivity, which looks at how well the tool catches children with ADHD, and the specificity, which looks at how often it mistakenly flags children without ADHD. Now, a perfect test would reach the top left all the way to 1.0. However, the diagonal dashed line represents a test that is no better than guessing. So both SDQ scores sit well above the diagonal line, which confirms the test has good accuracy. Now, the solid teal curve that you see there is the total difficulty score, and this achieved a AUC of 0.83, and the dash goal curve that you also see there, the overall SDQ total score, achieved the AUC of 0.81. Now, the dots on the teal curve marks the optimal cutoff point, which is a score of 18 or above, where you look for sensitivity, again, which measures the tool's ability to correctly identify ADHD, and that was 7 in 10 children who had ADHD, and specificity, the ability to clear more than 9 out of 10 children without ADHD. The high specificity is especially valuable in resource-limited settings such as our own, and this means very few children without ADHD are being sent for unnecessary testing and specialist appointments. So technically, it's just saying that the SDQ performed relatively well when screening for ADHD within the Caribbean population. The use of the SDQ total difficulty score with a cutoff of 18 is the first line screener, and a score of at 18 or above should prompt a comprehensive ADHD assessment and not serve as a diagnosis in itself. The strengths coming out of this study, the first one is that it's the first study of its kind. No one has ever validated the SDQ within the Caribbean population before, and even preliminary findings are a significant contribution. The multi-island sample adds credibility to some degree, although the sample was relatively small, and findings are not limited to one island or one community. However, the sample size was relatively small in other islands compared to Montserrat. So Montserrat had the higher number of participants in this study. Now, asking parents to share their experiences in their own words added cultural depth that numbers alone cannot capture. And we used a multiple statistical method that all pointed the same direction, and that is increase in confidence in the tool. The accuracy score of 0.83 and the very large group difference are genuinely encouraging results for a first generation study of this kind. Now, every study has limitations, and this is no exception. The most significant is that our sample size was relatively small, and we use the information, although useful, it's still not enough for us to make a generalization across the board. The second one is diagnosis was self-reported by parents, where we asked them to say whether their child had an official diagnosis or not. And again, this was not verified because it was done remotely. Thirdly, not everyone was equally likely to take part. Families who completed an online survey about ADHD may not represent all Caribbean families, so we need to keep that in mind. And we heard only from the parents. We did not look at teachers or the children themselves in this case, because the ADHD has versions. They have a teacher version, a parent-reported version, and a self-administered version. So we only looked at the parent-reported version. Now, despite all of this study is a solid first step, and the findings are consistent enough to be taken seriously while we work towards a larger validation study. Okay. Recommendations. Now, for clinicians, we want to use the SDQ as a first check, not a final answer. A score of 18 or above is a signal to look further, but always combine it with proper conversation with the family, teacher, and the child, and of course, other members who interact with the child on a daily basis. Now remember, the SDQ missed 3 in 10 children with ADHD. A low score does not mean all is well. If a parent or teacher is concerned, that matters too. We need to take that into account. For our communities, we need to talk more openly about ADHD. It is not a label or a life sentence. It is an explanation that helps children get the right support they need. For our policymakers, we're looking at having more investment in a larger validation study that can go a long way in early detection and management of families, starting with this study, and it deserves proper validation and region-specific screening tools to help facilitate this. For schools, we want to ensure our teachers and guidance counselors are trained to appropriately administer the teacher version of the tool and also the self-reported tool. This helps ease the burden on professionals having to do the work themselves, and a school teacher or guidance counselor who knows how to use the tool correctly can change a child's life by getting them help before they actually fall far behind. The SDQ shows genuine promise as a first-line screening tool for ADHD in the Caribbean. Children with ADHD scored about 9 points more on average than those without, a large and meaningful difference. The accuracy score was 0.83, a score of 18 or above correctly flagged 7 in 10 children with ADHD and correctly cleared 9 in 10 without. However, this is a first study with 50 families. We should treat this as a very encouraging starting point and not a final answer. And the most important message coming out of this is that the SDQ can help you identify which children deserves a closer look. It is a conversation starter and not a conclusion. Caribbean children deserve screening tools that were designed and tested with them in mind. And this study is the first step towards that. I think it. And thank you. Any questions?
No questions or comments for Nurse Lane? One.
Asking for a friend. Do we have the necessary tools, resources here on Montserrat to screen adults for ADHD?
Can I ask Mr. Bam to respond to that question?
Adults.
Yeah.
Well, thank you so much. We do not have screening tools, really, based on the fact that for an adult that will now be presenting for ADHD, we need to do better and deeper than just the screening tools. Call to mind now would be the need to do a detailed clinical interview and observation to harvest information from the beginning chronologically. That will do a better job in being able to make the diagnosis than relying on just the screening tools, okay? So if we go by that, we will now have to relate with the information we're able to gather from clinical interview and observation and align with the DSM-5 or ICD criteria to enable us to make proper diagnosis. Thank you.
Yeah, just to say that there is a screening tool for adult ADHD. It's called the ASRS, and it's freely available online to download and use with adults. But as Mr. Bam said, this is a comprehensive assessment involving the use of the screening tool, and then we go into further evaluation, clinical interview, hopefully multi-informant, so not just only speaking to the patient, but also those who are closer to that patient, so a relative who knows them well. If we can go back to their teacher, their school, look at their old school records to see if there was any hint about concentration and attention difficulties. What else? And then, yes, observation. And also, if they're adults, how they're getting on in the workplace, because ADHD will show itself in employment settings as well, and how they're getting on with the pace of the work and their ability to focus in meetings, etc., and take notes. We should also, as good measure, include a cognitive assessment. So in adults, that should be the WAIS-5. We're looking there to see, especially in the indices of processing speed and working memory, there should be relatively poorer results in those two indices relative to the verbal comprehension indices, the FRI, which is the fluid, that one, the fluid blah blah indices. There's 5 indices of the WAIS. Verbal comprehension, there's the other 3, and then, but what we're really looking at is the processing speed and the working memory. We're looking to see, relative to how they're doing to the others, are those two suffering? And that, although it's not a diagnosing thing, we're looking to see if it's matching in what we're talking about, because ADHD is really a dysfunction of the executive system within us. So we have executive functions in our brain, and ADHD struggles with executive functioning. So that's what we're really looking at. How good, or how good are they doing in executive functioning? Going back to the child patient, I've never used the SDQ to screen for ADHD. It's actually the Vanderbilt, which is the gold standard screen for a screening for ADHD. The SDQ, the problem with that is it's only 5 questions in that subsection of ADHD, whereas the Vanderbilt has about 45 items. That is the most robust, and it also has other subscales in there that go along with ADHD, such as conduct disorder, opposition or defiance disorder, anxiety and depression. So ADHD rarely travels alone. It's often correlated with autism, spectrum disorder, conduct disorder, mood disorders, and also specific learning difficulties like dyslexia and dysgraphia, etc. So, I mean, as a clinician, I think the Vanderbilt should really be the gold standard screening tool for children, not really the SDQ. So I might look at the SDQ for other things, but it's the Vanderbilt that should really take the focus in terms of seeing whether we're really doing a comprehensive ADHD assessment following the Vanderbilt, not really the SDQ. So that's my take on it. Thank you.
Just to respond to that, yes, during the research, we did pick up that the Vanderbilt is a more preferred screening tool. However, because of the cost implications, the SDQ came up as one of the least expensive to administer, especially in low-income communities and communities where they don't have specialists available to administer such a screening tool.
Good afternoon, everyone. Congratulations, Nurse Lane, on completing your master's. In terms of going forward, or since your return, have you implemented the tool? So, well, we heard now about the Vanderbilt, but have you actually done, outside of the study population, have you done any screening of children using the SDQ? And is there any plan in terms of like policy and standardization? So recently we started working on the mental health policy. I think that was more for adult care though. Is there any plan to standardize treatments and investigations screenings for children?
To respond to your first question, no, I have not used the tool since returning. And secondly, the policy does have a section that addresses children and young people. However, I don't think we went as far as going that detail in terms of identifying a standardized tool that we want to use specifically for screening ADHD within our policy. But it's something that we can look at and see which is best suited for Montserrat. Of course, we have to also see if it's validated to suit our situation. Of course, we have to consider cultural differences, social implications, and so forth. So it's something that we can look at in the future and see how we can work it in. Any other questions before I? No? Thank you all for listening.
Yes, so ladies and gentlemen, we have reached the end of our presentations for today. I think we can give all of our presenters a big round of applause. I will open the microphone for 2 minutes if anybody wants to provide any feedback on the presenters today and how they felt about what occurred. I see one person.
I just wanted to say thank you for inviting me here as well. Just a consideration, there's something that most people don't consider. Obviously, I'm the Minister of Agriculture, the Minister of Health isn't here, but the two ministries, especially when it comes to population and health, basically go hand in hand. There's many overlaps. Throughout the presentations, we've heard of prevention, we've heard of like maintaining persons who are sick and curing persons who are sick. And I almost thought that a lot of the presenters were looking at me when they were talking about food, etc.
I was.
I know you did. But what that basically shows is that we actually probably need to sit down between the two ministries and collaborate quite a bit more, especially when we're looking at preventing a lot of the non-communicable diseases that we're seeing emerging in Montserrat. I realized that you tried very hard to present the lunch in such a way that it was a bit more balanced than what we normally would see at our tables in Montserrat. Generally, we see a lot more starches in our diets, and I can't help but think that, okay, with our diets and its composition is the reason why we're seeing things like diabetes emerge, etc. Some of the data I was a bit surprised with, like especially when we're doing with the mental health issues, there were a lot of issues that dealt with women, where the women were responding to having a lot more depression. But I was just wondering, generally men don't generally come out and say that they're depressed.
Yeah.
And the two sexes generally deal with their issues quite differently. So what you might find is that there's actually some real overlap between the men being depressed and the women being depressed, but the men seem to be dealing with it by substance abuse, and that's not generally recorded. But what I really wanted to get to is, do we understand what's actually causing these levels of depression? Because I think it's happening in both sexes, but have we gotten to the root cause of it? Is it the economic situation? Is it social? What is it? Have we gotten to those root causes? How are we actually digging into what's really the issue and not just looking at the data that's only showing the effect? And again, I think that's where both ministries need to really come together. Exercise, obviously, is a good thing to bring up here. I know that generally we have the walks that we go out with. I'm the Minister of Sports. There is a sports policy that we are working on, but I think overall, I think both ministries really, really need to collaborate more often. I would suggest maybe even quarterly to see how we go about fixing a lot of these issues. Healthcare is expensive, but it's a lot cheaper to prevent people from getting sick in the first place.
Very true.
And if we're going to look at healthcare, yes, we have to look at the food standpoint. I think that's the most important. Again, if we eat naturally, and we talk about chicken and antimicrobial resistance, again, imported chicken would be one of your sources of that, because we know that they use a lot of antibiotics in imported chicken. the chicken that are locally produced don't use antibiotics. And again, because they're doing mass production overseas, and they have a lot of these chicken in these small confined areas where disease spreads quite easily, they use antibiotics to kind of increase their yield. We don't do that locally. So while it may be a little more expensive to produce chicken locally, perhaps we need to start actually gearing people or steering people towards eating a lot more of the local foods. The good thing to state here now too, a lot of our local farmers are now becoming aware of what pesticides and other chemicals do. And some have reported that they don't want to use these kind of chemicals. So we're now looking at greenhouse production, shade house production that allows them to produce without having to spray for bugs, etc. So I think as long as we collaborate using the data that you have, using the data that we're now collecting as well, and data is very important, we can kind of put Montserrat on a better track where we're not just reporting the amount of health issues that we're having, but we're reporting that each year after we're starting to see the reoccurrences of these NCDs, etc., lower. So again, thank you. I think you guys are doing a great job. I will support you even if I'm in another ministry, however I can. I do have a degree in biology. So I do understand everything that has been presented here. But again, continue to do the great job that you're doing. I know it's not always the best circumstance, but we will support you in whatever way we can.
Yes. Thank you very much, Honorable John Osborne. I would second his idea that we as ministries need to collaborate more. Health, we can't do everything independently. It's mission impossible, but together we can. Yes, that's a lovely slogan. Together we can. So I look forward to more collaboration between the ministries. So those of you with agendas in hand, you may see a word there at the bottom that says awards. So I didn't really publicize it, but I did ask 3 persons in the audience today to pay keen attention to the presenters and to come up with some very important awards, for want of a better word. And we are going to we want to recognize hard work. A lot of hard work, a lot of effort went into each and every one of these presentations. So we focused today primarily on just the persons who did in-person presentations and not the virtual presentations. And my team of 3 have come up with a best presenter and a most impactful research piece. So I'm checking to see if they're ready. I see smiles. So I see Dr. Georgette Skerritt. She will tell you who the 3 were, and she will say who those persons are. 3 of you.
Okay, good afternoon again, everyone. So, you know we like to do new things. So Penny came up with the idea this year to introduce a point system and awards for our presenters. Firstly, I would like to commend all of our presenters on a job well done. It takes a lot of nerve to come up here. Well, firstly, it takes a lot of time and effort to get the research done and then put it together, analyze it, and present it to you and the rest of the world, because we have persons listening from all over. So thank you to everyone on a job well done. All right, so Mr. Bamishile, Nurse Gray, Sister Gray, and myself were tasked with the hard job. And we will be giving 2 prizes, 2 awards, one for the best presenter and one for the most impactful research, right? So in terms of the best presenter, the criteria, all right, so the criteria, if the presentation was clear and well organized, knowledge of the topic, confident and engaging delivery, effective use of slides or visuals, answers questions well, and keeps within the allotted time. So for that award, so we put all our scores together and averaged it, right? So it's not biased. And the person who won Best Presenter was Dr. Tiffany Skerritt Fleming with 97.6%. Right? So she was very engaging, confident, knowledgeable in her topic, and did well with her time as well. Yeah? In terms of the most impactful research, the criteria included the research addresses an important issue in Montserrat, could improve health or healthcare services, recommendations are practical and realistic, research findings are clear and supported by evidence, could influence policy or practice. And the winner for that award is Dr. Dorothea Hazel Blake with a total of 96.6%. Dr. Blake? Yes.
Do we have anybody to collect on Dr. Skerritt Fleming's behalf? All right, yes. As a member of the research team.
Yes.
Perfect.
All right, sorry. As I said earlier, don't go too far. On behalf of the entire team, is Nurse Jubri here? She's already left. And I really want to give a big up to my colleague, Mr. Bill Berners-Lee, who worked tirelessly even while abroad in assisting. And so I accept this on behalf of the entire team. Have to look pretty?
Yes. Congratulations.
Thank you.
Continue to keep up the good work. Thank you.
I will now invite Ms. Charlene Lindsay to present our vote of thanks. And after that, you are absolutely free to go. Thank you all for being here. Thank you again to our presenters. And I look forward to seeing you all next year.
Good afternoon, everyone. As Mrs. Maloney said, I have been tasked with delivering the vote of thanks. Firstly, we'd like to say a big thank you to Honorable Cranston Buffon, who is the current acting Minister of Health. Thank you to Honorable John Osborne for popping in as well. To all of our presenters for all your research, hard work, and dedication to the cause, we say thank you. Today would not have been possible without you. GIU, thank you very much for our live stream and technical support. iTech, thank you for the sound. All you could hear me? Yeah, all right. Dr. Georgette Skerritt, Sister Charmaine Gray, and Mr. Bamishile for assessing the presenters for most impactful presentation and best presenter. We say thank you. Rosanna Collins, she is a visiting, was visiting, she left today, and visiting epidemiologist who conducted studies, assisted researchers, and helped to organize this event. Thank you to our chairperson, Mrs. Penny Maloney, the acting director of primary healthcare. And we say thank you to Charlene Lindsay, who was an integral part of planning and executing today's event alongside Mrs. Maloney and Rosie Collins. And of course, we say thank you to you, our audience in person and online. Thank you for helping to make Research Day 2026 a success.
thought they got snatched up during lunchtime. I thought they'd get snatched
Please take your garbage with you. Let's leave with the Ministry of Health's good name that we